Hello, everyone. Welcome to the first EAPOS Young Ophthalmologist session. That's an event of its own that we have been seeing a lot of webinars across the last few months, but this webinar, we promise it's good. You will enjoy it. Really promise for this to happen. Just since this is the first time for us to for anyone to have this young ophthalmologist session with competition between teams online, so this is the first experience for us for this. So what we did our best to make it as fun as we can and as informative as we can. I would like to welcome all the audiences who have been attending with us, and I would like to welcome all the speakers that young ophthalmologist speakers that start to speak, and of course I would like to welcome all the judges and discussing with us and my colleague moderators. Starting with the first thing I would like to share with you. That will be the event for tonight, free talks and competition. These are the two parts that we'll have. We'll start first with the free talk section, and then with the competition section. First of all, I'm glad to introduce Professor Dr. Mohammed Al-Sada. Of course, you all know him very much. He is Professor of Ophthalmology, Cairo University, and he's the President of the Egyptian Association of Pediatric Ophthalmology and Strabismus Society. And I'm asking Dr. Mohammed Al-Sada to give his introductory talk. Dr. Mohammed, the mic is yours.
Good evening, everybody, dear audience, dear colleagues. I would like to welcome you very much to this webinar organized by the Egyptian Society of Pediatric Ophthalmology and Strabismus. Actually, this society has a long story with young ophthalmologists. Since the very beginning, one of the most important aims of this society was to encourage the young ophthalmologists to understand and practice better pediatric ophthalmology, and as well encourage the general ophthalmologist to understand and know better of pediatric ophthalmology so that he can improve his own practice. So, in other words, we have a very important national role, and this session is a part of this role in order to promote the young ophthalmologist training. In addition to our national role, we have as well a regional role, and this is why we are very pleased to have with us tonight Professor Amal Alhemidan from the Kingdom of Saudi Arabia, from Riyadh. And we would like very much to expand our efforts with all the regional countries in the area. And finally, we have an international role that we are already practicing in order to collaborate with the international societies interested in pediatric ophthalmology. I thank very much the judges who are with us tonight. They are all very eminent people. I know that their time is very precious, but in spite of that, they have insisted and welcomed us attending with us this young ophthalmology webinar. So I thank them very, very much. And I would like also, and specifically, to thank the organizer, Dr. Ayman, Dr. Heba, Dr. Sameh. It's a great effort in order to organize a meeting like this meeting, a webinar meeting like this meeting. It is not easy. It is not easy to collect the appropriate presentations and to organize it on a webinar items and to present it. They did really a great effort. So I thank them very, very much for that. And I leave now the rest of the webinar to our moderators.
Thank you, Dr. Mohammed, very much. Yeah, I know very much that how you are really interested, and you have a special care, anything related to young. Medical metry city in Riyadh, Saudi Arabia, and she's a representative, and she's the representative of the Saudi Pediatric Ophthalmology Association. And we are pleased to have you. Welcome, Dr. Amal.
Thank you, Dr. Ayman, and it's really my pleasure to join you tonight. It's really an honor, and I'm pleased to be part of the judges. I hope I'll be a helpful person, and I'm really pleased to see this big group of participants already online with us. Tells us how much, at least this is a promising future for pediatric ophthalmology. I know in most of the, if we compare pediatric ophthalmology to other subspecialties, it's not really very popular. So when I see a big number of participants here, I'm very optimistic, become optimistic that more and more young ophthalmologists are interested in this field. So I hope all the best of luck for everyone.
Thank you very much, Dr. Amal. Thank you very much.
Good evening, everyone. I'm very happy to welcome all guests, and thank you, Dr. Muhammad Sada, for letting us organize this prestigious meeting to introduce the national figure, Dr. Dalal Shawky, Professor of Ophthalmology at Alexandria, Egypt, and currently she's the president of Egyptian Ophthalmic Society, and she's a member of the EAPOS board. Thank you, Dr. Dalal, for coming and giving us this honor of attending this webinar. Again, I'd like to introduce...
Thank you, Dr. Sameh, for your nice words. It is my honor to participate with you, really. Thank you.
Thank you very much. I'd like, again, to welcome Colonel Dr. Hisham Khattab. He's a very big name in strabismus and pediatric ophthalmology, and he's a pediatric ophthalmology and strabismus consultant in Egyptian military hospital. Thank you, Dr. Hisham, for attending and giving us precious time. We have again Dr. Hatem Saeed, the big pediatric ophthalmologist, and he's a professor of ophthalmology in Cairo University and a fellow of Wilmer Eye Institute, Johns Hopkins in the United States of America. Thank you, Dr. Hatem, for your precious time and giving us this chance to share with us this webinar. Again,
thank you, Sameh. I'm very honored to participate in this event. The microphone was muted.
Thank you. And our moderator board, we have Dr. Ayman Elghonemy. He's the pediatric ophthalmology consultant in Memorial Eye Institute of Ophthalmic Research and Maghrabi Eye Hospitals, and EAPOS board member, with my friend and colleague, Dr. Heba Metwally, pediatric ophthalmology consultant in Memorial Institute for Ophthalmic Research and Maghrabi Eye Hospitals, and myself, Sameh Galal, lecturer of ophthalmology and pediatric ophthalmology consultant in Research Institute of Ophthalmology.
Thank you, Dr. Sameh. Thank you. So next, we will start the first section, the free talk section. Dr. Heba, the mic is with you.
Thanks, Dr. Sameh, for your nice words. Thanks, Dr. Ayman and Dr. Sameh, for working with me on this huge event. And thanks, Professor Dr. Muhammad Sada, and thanks for the EAPOS board for inviting me to this meeting. Today, I'm so excited for tonight's meeting because I'm in the EAPOS, my big house, big home, and big family. I think I expect to have a lot of fun and a lot of knowledge today from all the speakers and the judges. And let's get down immediately and start our free talk section. But let me first to present to all of you 10 possibly future stars of our young ophthalmologists. We have on the board Dr. Christina Samir Ibrahim from Qasr Al Aini Hospital, Children Hospital, and we have Dr. Ron Mohammed Abdel Hamid from Qasr Al Aini Children's Hospital, Dr. Yasmin Migdad from Qasr Al Aini Children's Hospital, but Dr. Yasmin apologized unfortunately for the last moment, and Dr. Amr Magdi from Memorial Institute for Ophthalmic Research will replace her. We have also Dr. Nader Montez from Memorial Institute for Ophthalmic Research and the Memorial Institute Kids Eye Center, Egypt, and we have Dr. Isra Muhammad Abdel Monaim from Research Institute for Ophthalmology. All the previous speakers were from Egypt, and we have also Dr. Dua Ashraf Hassin from Ben Suef University Hospital, and we have many guests from outside Egypt. We have Dr. Smeta Kapoor from India. We have Dr. Nawar Shohedi from Syria. We have Dr. Abdullah Ahmed Al-Awaidi from King Khalid Eye Hospital from Saudi Arabia. And we have Dr. Abdi Rizlan from Morocco. Let me tell you the regulations of our sessions. We have a very strict regulations. You just have 5 minutes for your talk. Please don't exceed and stick to your time because we have many talks and many details today. After the end of your presentation, the audience poll will be raised immediately, and we will have the audience vote for your talk. Please, we encourage all the participants in the audience to vote for the speakers, because your vote is very important for all of us to choose the best winner. And then the judges will give the scores on your scientific content and presentation skills as well. So we have three scores on scientific content, presentation skills, and the audience score, and we will collect and gather the score, and will be your score at the end. And let me tell you and share the orders of speakers. And now let's get down and start the first talk. I invite Dr. Christina Samir to share her screen. I will stop sharing my screen. Please share your screen and start your presentation. And I invite all the judges to be ready for Dr. Christina talk and presentation. Christina, you just have 5 minutes from the first moment you start. Dr. Christina?
Okay. Yes, just, yeah.
Good evening.
Yeah, thank you. Just the video is cannot be shared by the host. Okay, you hear me?
Yes.
Yeah, okay. I'm Christina, resident of ophthalmology in Cairo University. I'm here to introduce the intraarterial chemotherapy, the game changer in the retinoblastoma. It's a case series from the Ocular Oncology Service, Cairo University. As we know, retinoblastoma is the main intraocular tumor under the age of 5 years, and it should be excluded in every case of leukocoria. Before the radiosensitivity and radioprognosis on which basis the old risk classification of Ellsworth, and then shifted to the chemotherapy. So the international classification of retinoblastoma has been established to give the prognosis of the patients from into 5 groups, from group A to E. A is the most advanced. It's based on the size of the tumor, presence near the macula or the optic nerve, and presence of seeds, and its distance from the tumor. The management goals is the first priority is to save the life of the patient and preserve the globe, and then to save vision. Here, what are our game players? We have the focal therapy in the playground of treatments. We have the focal therapy with its modalities. We have the chemotherapy, and we have enucleation. Systemic therapy, its main goal to do chemo reduction is to reduce the size of the tumor to be able to apply for focal therapy. But it has its systemic toxicity, and it doesn't control the vitreocytes, which is a major drawback in its cause of recurrence, and in many cases it ends with enucleation. So how we can provide the treatments or the therapeutic agents into the eye with a higher concentration, with least systemic toxicity, and That's how our game changer came. It's to produce a therapeutic agent from the femoral vein into the ostium of the ophthalmic artery, what's called the intra-arterial chemotherapy or super selective intra-arterial chemotherapy. It's targeted therapy towards the tumor. Addition of the intravitreal chemotherapy to control the vitreal seeds is a very strong weapon to control the tumor, and it's very high success rates. We use malphaline and topotecan, and the other one has a 5 times higher concentration in the vitreous. And this is the dose that's used. So let's start our cases. Here is a patient presented with exotropia, with the second most common presentation in retinoblastoma. Here see the seeds, and here is the mass. Do ultrasound to see the internal reflectivity high and calcification and wide base of the tumor and high. So cannot produce or use focal therapy right now. So here use do UBM first, because it's anteriorly encroaching anteriorly and have this seed less than 3 millimeter. MRI was normal. So according to size of the seed, it was group C. Intraarterial chemotherapy and intravitreal injection of malphaline is used, and then look after 1 month post-operatively to see this anterior seed completely disappeared, with the size of the tumor decreased to 50% almost of its original size. So brachytherapy with COP plaque, ruthenium plaque is applied, and a second injection of intravitreal malphaline with applying or application of the cryotherapy at the site of the injection. Then look after 3 months as a tumor is reduced and it's become calcified, regressed. A second case of a large mass occupying almost most of the posterior areas of retinal attachment, and it's a group D. And again, it shows that it's a broad base. We cannot apply once more the focal therapy. IC or intraarterial chemotherapy is applied. And look, after 3 weeks, now it's reduced. So we can apply now brachytherapy, and here brachytherapy after chemo reduction is done. And look after that's after the brachytherapy. But the patient did well for 4 months, and then we find a regrowth of the tumor. So this time enucleation is done, and the pathology found that there is no involvement of the optic nerve or the sclera, so systemic chemotherapy is not given. Here is a bilateral retinoblastoma. The right eye is almost involved here. The whole globe is almost involved in this T2 weighted images. It's the hypodense lesions. The left eye have 2 foci. CT tapping done under the with the advice of the oncology team. So no malignant cells found. Enucleation done for the most advanced eye, and 2 injections of malphaline intravitreally done for the left eye. And here reduction of the tumor started. Then the patient underwent brachytherapy and chemotherapy, and this is the CCP radioactive plaque. The last case, it's a 5 months it's a 5 months old boy with a bilateral retinoblastoma. Here is the left eye. It's almost occupied completely with the tumor with retinal attachment, and then the left eye, here is another mass with seeds away from 3 millimeters away from the tumor. So the less advanced eye is group D, and more advanced is group E. And MRI done, no bineroblastoma, it was normal. And then enucleation for the more advanced eye is done. Here you find the mass, and then the other eye.
Dr. Christine,
here it's a, yes.
Please stop your share. Unfortunately, we will miss your first case. We had a very strong start from Castle Lady Hospital. Usually about the retinoblastoma, I asked the IT to publish the audience poll.
Yeah, okay.
I invite the second speaker, Dr. Nawar Shuhaidi from Syria, to share his screen. I encourage you all to participate in the voting. We want very heavy participation. Please vote for Christina. She gave a very, very strong and very interesting presentation about retinoblastoma. Vote for Christina. Would you please publish the results of the vote? So we had an excellent moving to the second speaker, Dr. Nawar Shuhaidi from Syria. Please, Dr. Nawar, go ahead. The platform is yours.
Good evening, my doctor. I'm Nawaz Shahade from Syria. Glad to be with you on this webinar. Today we have a case report. Today we have a case report about hypotropic dissociation vertical deviation. Let's say first that DVD is characterized by the slow vertical drift of the non-fixating eye, or when we cover one eye. Upward shifts are common and usually accompany congenital esotropia and latent nystagmus, but downward drift is very rare and only 10 cases have been reported in literature. These tables show the 9 cases, reported cases, and their clinical characteristic. We see here, for example, that all the cases are unilateral except of 1 cases, and that there are most of cases have a low visual acuity in the hypodeviated eye. The last case I have found it is in 2013 for a 25-year-old female with unilateral esotropia, hypotropia, and downward drift in her left eye. Our case report is about a 4-year-old girl presented with intermittent exotropia of both eyes since the age of 7 months without any prior therapy. She was apparently in good health, and cycloreflection is presented here. She has a mild hypermetropic refractive error. These tables show that the measurement of the exodeviation for near, for example, is about 30 prism diopter, and for far is about 50 prism diopter, and she has significant V pattern with bilateral inferior oblique overaction secondary to bilateral superior oblique underaction. The fixating eye is alternative, and the exodeviation is very variable due to the important DVD in the both eyes. She has manifest latent nystagmus in both eyes that decrease significantly when she look down. And so that she has anomalous head position by chin up to
Dr. Nawar, I can't hear your voice.
She has a technical error, I think.
Okay. Dr. Nawar, please, we cannot hear your voice. Okay. Dr. Nawar? I think, Dr. Nawar? So I think we move to the next speaker. Please, Dr. Nader. Dr. Nader, please.
Yes, I'm here.
So I invite you all to vote for Dr. Nawar. Unfortunately, she had a technical error.
Let's give a chance if she came back. Let's
okay. Yes. And, let's give her another chance to come back and retry at the end of the section of the session. Please, Dr. Nader, start sharing your screen. We will give Dr. Nawar another chance at the end of the session. Please don't vote for her.
Yes, we will not count this vote. If a connection has been good.
Please, Dr. Nader, start share your screen.
Is it clear now?
Yes, we can hear you.
Okay, good afternoon, dear professors, doctors, and colleagues. It's a great honor to present in the first EAPOS Young Ophthalmologist webinar. Today, I'm presenting a congenital glaucoma trick. So our patient is a 2-month-old infant, full term. Her mother is coming with a complaint of redness, tearing, and an enlargement of her left eye since birth. She was referred as having left ophthalmos. This is the picture of the child. The left eye, the first look, this is not ophthalmic, but maybe slightly enlarged. From this view, we can see that's slightly enlarged or proptotic. This is another view that the left eye is slightly enlarged, and there's a scleral show here. Upon crying, the proptosis increased, and you can see clearly here that there is puffiness also along the upper and the lower eyelids. So we decided to do for her examination under general anesthesia. For the right eye, it was perfect, and for the left eye, only there was conjunctival congestion and there was slight proptosis. The IP was normal using the Perkins and confirmed with eye care tonometer. So we decided to think, what is the differential diagnosis of this case? This is the long list of epiphora, maybe macrophthalmia, and as the first presenter said, retinoblastoma is the most serious condition, and we must think of retinoblastoma, and also maybe axial myopia, glaucoma, melanoma, or other collagen disorders. Proptosis in this age group may be developmental, orbital cellulitis, so there's infection, vascular malformations, neoplasms, or inflammations as orbital pseudotumor. And we should not miss the classic triad of epiphora, photophobia, and blepharospasm of patients with primary congenital glaucoma. And these are two pictures from patients at our center. So back to our child, after crying, there is obvious that there is dilatation of vessels around the eye. So we decided to do more investigations. Please, for these children, please do MRIs and not CTs, and we will know why. Clearly here we can see a dilated superior ophthalmic vein, and from this view also the superior ophthalmic vein dilatation appears. Upon doing ultrasound, we could see the dilated vessels here and here. So we came to the diagnosis of orbital varices. That's they are venous malformations, vascular hamartomas that commonly present in the early childhood. And for MCQ questions, these are unilateral and located supranasally. The symptoms, proptosis is the main sign. It's intermittent, slow progressive, that increases upon Valsalva maneuver, as this case upon straining due to crying. The most important complications are the orbital acute hemorrhage, thrombosis, and optic nerve compression. Mainly conservatively, it's managed conservatively, but the main indication for surgery is the optic nerve compression. Excision is done, and there are other specialized techniques for this patient. We send her to the interventional radiologist for endovascular microcoil embolization, and she did perfect. Other specialized techniques are the glue embolization, the alcohol sclerotherapy, and the carbon dioxide laser surgery. This is really a case report because the lowest age presented in the literature is 7 years, and this case is almost 2 months old only. So our messages, our stay connected messages at the era of COVID-19, that primary congenital glaucoma can be misdiagnosed by certain conditions. Proper history taking is always the clue. Cornea and optic nerve are the keys to diagnose primary congenital glaucoma, and orbital varices can cause and can be presented by glaucoma. And please, if you suspect retinoblastoma, please request MRI and not CT for the fear of Newton double hit hypothesis. And thank you.
Dr. Heba, unmute.
Thanks, Nader, for the very nice presentation and the very nice and helpful take-home message. Please, for all the audience, vote for Nader. He said a very, very interesting presentation, and I ask the next speaker, Dr. Isra Abdelmunayem, to share her screen. So Nader was excellent. Thank you, Nader.
Thank you.
Good evening, everybody. This is me, Isra Abdelmunayem, an assistant lecturer in pediatric ophthalmology fellow at the Research Institute of Ophthalmology. I'm very happy to join the EAPOS as a young ophthalmology speaker for the first time, and it's a great honor for me to be part of this magnificent scientific meeting. I'm gratefully thankful for all my dear professors, colleagues, moderators, and hoping you're all in a good health. The head-most where the eye can't move, the abnormal head posture that I'm going to present today. Special thanks to the Dr. Ahmad Hanoun, my dear professor, is here, who helped me throughout this presentation. Remember, the aim of abnormal hair posture is to see better and to see binocular. To see, this is an example of a patient with bilateral ptosis that adopted chin elevation in order to see. To see better, we have different examples of seeing better. This patient with mal-corrected astigmatism adopted abnormal hair posture to overcome distorted image, and after properly correcting his glasses, abnormal hair posture disappeared. This is a video of null point nystagmus with rapid face toward the right side and null point toward the left side. This patient adopted right face turn in order to put his eyes in the position with least nystagmus to see better. Well, to see binocular, we have different types of abnormal hair posture. Face turn. It's mostly due to horizontal and maybe cyclovertical. Cyclovertical in the form of oblique vertical recti, it would be ipsilateral, or oblique, it would be contralateral. Here are some examples of horizontal face turn, like right 6-nerve palsy with right face turn, on occluding one eye, abnormal hair posture disappearing. This is a right traumatic medial rectus paresis with right face turn, and this arrow is showing the limitation of adduction in the left eye with face turn, and this is an example of vertical Brown syndrome, limitation of elevation and adduction in the left eye, left Brown syndrome with contralateral face turn. Again, to see binocular, head tilt is an example. Intorters usually adopt contralateral head tilt, while extorters usually adopt ipsilateral head tilt. This is a case of a left fourth nerve palsy with positive head tilt test toward the left side and increasing vertical deviation in the right gaze with right head tilt. After correction and 6 weeks post-operative, the patient developed left head tilt. This is a case of masked bilateral fourth nerve, which is not uncommon. Another case of left inferior rectus palsy with left head tilt, left inferior oblique palsy with left head tilt. Again, to see binocular, we have some examples of chin elevation and depression. Elevator, depressor, pattern, or unilateral ptosis. This is an example of chin elevation in a child with limitation of abduction in the left eye. This is a case of Brown syndrome. Another case of left inferior rectus restriction with chin elevation due to improperly corrected orbital floor fracture. And this is a case of unilateral ptosis with chin elevation. This child adopted abnormal hair posture. That means she has a good binocular. In complex torticollis, this child is an example with left face turn and chin depression, right fourth nerve nystagmus. In this video, we're going to show that this child has also nystagmus with rapid face toward the right side and now point toward the left. This patient adopted left face turn. Left face turn here is a double cause due to fourth nerve palsy and nystagmus. How could we differentiate? Okay, by covering one eye, the child abnormal hair posture disappeared, and that means that this child adopted abnormal hair posture in order to see binocular and not to see better due to nystagmus. Abnormal hair posture take-home message mostly is an evidence of good binocular vision and fusion. Generally, abnormal hair posture is in the opposite direction of field of action of the affected muscle. Head tilt is related to vertical deviation rather than previously thought as torsion. Please remember superiors are intorters, contralateral head tilt, while inferiors are extorters with ipsilateral head tilt, while in face turn it's different. Vertical recti are ipsilateral and obliques are contralateral. Thank you so much.
Thanks, Dr. Isra. It's feels so good that you all stick to your time. Thanks for the nice presentation. You gave a very and examples. So please vote for Isra from Research Institute for Ophthalmology. Ophthalmology, please vote for Isra. I ask our next speaker, Dr. Abdullah Al-Ubaidi from Saudi Arabia, to share his screen. Good job. You had a great voting from the audience, Dr. Isra, from the audience. Thank you. Dr. Abdullah?
Yes, Dr. Heba.
Good
Can I
evening.
start?
We can hear you.
Yeah.
Go ahead.
Thank you so much. My name is Abdullah Louid. I'm a pediatric fellow from KK Saudi Arabia, and I would like to thank the organizing committee for accepting my case today. So this is a 3-month-old baby girl presented to our emergency. The mother noticed the bleeding inside the eye since 3 weeks, started in the right eye, then followed by the left eye 2 days later. There was no history of recent trauma, no family history of sickle cell, bleeding disorder, glaucoma, or poor vision since childhood. She was medically free. The general physical exam showed a quite an active baby. There was a multiple hyperpigmented macules in the inner thigh with the right upper arm, with one pinkish papule over the occiput measuring about 1 millimeter in size. And this will highlight for you the importance of general physical exam in these children. There was no signs of any physical abuse or trauma. And as you can see here in the examination, there was a mild injection in both eyes and the conch. Cornea, there was mild corneal cloudiness. The pupil, there was on the right eye, a yellowish membrane mixed with the blood, and the left eye, it was round and regular. The AC was deep in both eyes with less than 1 millimeter hyphema in the right eye and 4 millimeter hyphema from 3 to 9 o'clock in the left eye. The IUP was 25 and 24, and the fundus had a hazy view, but the peripheral looks normal. So as you can see here, this is the papule over the occiput, and you can see here the bilateral hyphema. The right eye, there was a membrane mixed with the blood, and the left eye from 3 to 9 o'clock, you can see the hyphema bilaterally. So the rest of the physical exam was unremarkable. So we admitted the baby, and we started on full anti-glaucoma and PRID 40 drops in both eyes. The child was admitted for examination under anesthesia plus shaving biopsy of that occipital papule for histological examination. So under the examination under anesthesia, the same examination finding, the IUP was 23 before intubation, B-scan and UPM was done also, and the decision was made not to interfere surgically by the pediatric team. The oculoplastic team was kind enough to join and to do a shaving biopsy for that occipital papule, which was sent to histological studies. As you can see here also, the UPM, there was a 360 degree of narrowing of the angle, and the B-scan was normal in both eyes. So the baby was kept inpatient for monitoring, and we scheduled her for examination under sedation plus MRI, because it's important to rule out other causes of hyphema in these children as retinoblastoma or any brain problems. So the hyphema on that day was better than before, and there was a mild corneal staining. So the baby was discharged on full anti-glaucoma plus the PRID 40 drops. As you can see, this is her MRI, which was normal. So 2 weeks later, she presented again with high IUP. So we admitted her again, and we started this time an oral acetazolamide or Diamox. So 2 days later, the IUP normalized. And at that time, we had the diagnosis of juvenile xanthogranuloma confirmed by showing a total giant cell in the histological studies. You can see here in the histological studies, there are multiple foamy cells with few Tauton giant cell, and it's important here that you have a negative staining with Langerine and CD1 to rule out a Langerhans cell histocytosis, which is another differential diagnosis of juvenile xanthogranuloma. The patient was then discharged, and a follow-up was given 3 weeks later, yet she presented again with high IUP and pre-bleeding. So on admission this time, we give a single dose of peripulpar steroid injection in the form of methylprednisolone 10 milligram, and the IUP normalized and the active bleeding resolved, but there was a staining after 3 days, and the baby was sent home with the same topical drop for a 1 month duration. After about 5 months of being admitted and readmitted again, the bleeding now resolved, and the IUP is normal, but with a mild corneal staining. We're still following the child in a regular manner. So a few talks about juvenile xanthogranuloma. It's an uncommon form of a Langerhans histocytosis inflammatory disorder that usually characterized by a few giant or Tauton giant cells. The skin lesion may vary size a few millimeter to about 20 millimeter, and it can be found in anywhere in the body, including the spleen, lung, and GIT. Although spontaneous hyphema is important, you have to rule out other causes of hyphema, such as trauma or retinoblastoma, leukemia, or blood dyscrasis. Steroids, radiation therapy, surgical excision have been reported as possible treatment option for ocular juvenile xanthogranuloma.
About 30 seconds remaining.
the take-home message, juvenile is difficult to treat, but the correct diagnosis could help in preventing the complication like glaucoma, rebleeding, corneal blood staining, and amblyopia. And it's important to examine the child fully, looking for finding which could help you to reach the diagnosis. Don't look only to the eyes. Thank you.
Thank you, Dr. Abdullah Al-Awaidi. It's always a pleasure having guests from outside Egypt to present in our EAPOS. Thanks for your presentation. I invite you all to vote for our guest, Dr. Abdullah Al-Awaidi. I invite next speaker, Dr. Nuran, from our beloved Qasr Al-Aini Hospital, to share your screen. Excellent. You had an excellent voting, Dr. Abdullah. Congratulations. Dr. Nuran, good evening. Can you hear me?
Good evening, Dr. Heba.
Would you please speak up?
Okay. Good evening, everybody, dear colleagues and professors. It's my honor to present today in this great webinar. I'm Assistant Lecturer of Ophthalmology from Cairo University, a dosing study of intravitreal bevacizumab for RP patients. As we know, RP is one of the foremost reasons for childhood blindness. Previous studies reported a high vitreous level of the VEGF in those infants. The BEAT-RP study results showed the effectivity of bevacizumab in treating RP. However, this bevacizumab can escape the eye and circulate systemically, reducing the serum VEGF level in these infants, which is extremely important for the development of their vital organs. And accordingly, it's important to use the lowest possible effective dose, which is not defined yet. For us in Abu Rish, we still use the half adult dose, which is the 0.625 milligram. And here comes the aim of our work, to decide whether half the standard dose, a 0.3125 milligram, will be effective in treatment of type 1 RP or no. Patient population, this is a prospective comparative interventional study conducted in our RP unit between March 2019 and March 2020. We included 40 eyes of 20 infants, 20 eyes in each group. Group received the half dose and the group received the full dose. Success criteria to the IVB injection was defined as recovery, of course, of the plus disease, regression of any stage of RP, and full peripheral retinal vascularization. Meanwhile, also blood samples were obtained from those infants before, 1 week, and 4 weeks after injection to measure the systemic serum VEGF levels using specialized ELISA kits. Our primary outcome was to find the difference in the serum systemic VEGF between both groups and to detect the number of infants without a need for rescue therapy until 60 weeks post-menstrual. Rescue therapy was defined as that any infant who needed another full dose or a laser treatment during the early follow-up. Our results showed that a total of 30 eyes of 19 infants were included. Retreatment was needed in 4 infants, which means 8 eyes in the half-dose group and 5 infants in 10 eyes in the full-dose group. Again, the systemic levels of the serum VEGF did not show any statistical significant difference between both groups and in each group alone regarding the pre and the post-operative levels. Here are some examples of the half-dose patients. We can find this patient with a stage 2 zone 2. Here is the ridge in front of us, and the plus disease is very prominent. This patient, post-injection, he was fully vascularized except a small temporal crescent after he took the half dose. This is another case with bilateral stage 3. The difference between stage 3 and stage 2, now the ridge is vascularized and with new vessels, and the arrow can show the arteriolar tortuosity, which is very prominent. Post-injection, this baby, the right eye, we can find that the arterioles started to straighten and the vessels are reaching to the periphery of the retina, but still his right eye needs a follow-up. His left eye is totally normal. Another case of aggressive posterior ROP, we can see prominently the fanning of the vessels and a fragmented even ridge at the end of zone 1. This patient, unfortunately, did not improve from 1/2 dose injection, and he needed another full dose injection, and he passed good with a stage 1 or even 0 in zone 3. Some examples of the full dose, we find here a patient with stage 3 zone 1, and the arrow can show us a looping of the vessels. Now the vessels cannot even encroach more. Post-injection, the plus disease resolved at all, and the vessels reached up to the laser marks. Another case with a stage 2 mid zone 2, we can see scanning of the vessel, stopping at the ridge at the mid-zone 2. Pre-injection, the plus disease very prominent to us. Post-injection, fully vascularized, the vessels reaching almost the anterior retina and regression of the plus. Another case of aggressive posterior ROP. Pre-injection, we can see the avascular retina was 360 degrees. Post-injection, regression of the plus, and the vessels again reached to the anterior retina. The last case of aggressive posterior ROP was typical, did not improve from the first full dose injection, neither from the second full dose injection, and needed a laser the week after. So to conclude, the dose of 0.3125 showed the same efficacy in the treatment of type 1 RP compared to the standard dose we always use in English. Aggressive posterior RP cases is a high risk of retreatment, and further studies are still needed to determine the correlation of intravitreal injection of anti-VEGF with the systemic serum levels of VEGF. Thank you, and special thanks to Dr. Dina Hassam, who helped me a lot in this presentation.
Thanks to you, Nuran, and thanks to Dr. Dina for this very hot topic, the ROP. And it is as expected from Qasr Al-Aini Hospital. I invite all the audience to vote for Dr. Nuran from Qasr Al-Aini. She gave a very interesting presentation and review on ROP management. And now we will invite nobody to share his screen, and we will have a 5 minutes for discussion with our respectable judges. And I'd like to hear, to listen to their opinions about the talks. Dr. Dalal. Dr. Dalal. Good evening, Dr. Dalal. Can you hear me?
Please, all the judges, unmute your mic, please.
Dr.
All the full judges, please unmute. Please open your camera for the judge.
Yes,
please.
it is unmuted. Yes.
Yeah, already you are unmuted. I can hear you.
Okay.
Do you have any comment about this very nice
Yes.
5 presentations or 6 presentations?
All these presentations, really, I appreciate. They're excellent, really excellent, and are really on time. I have just one comment because it is my subspecialty to take a home message for Dr. Isra about the abnormal head posture. Just to put in mind, the head goes where the eye should go. This is summarizing everything. Paralysis of an abductor, the eye goes to the same side of the muscle not working. Just to put this in mind. And all the presentations really are excellent. I appreciate all of them, and it is a very nice competition.
Thank you, Dr. Dalal. Thank you. Moving to Dr. Amal from Saudi Arabia.
Yes, can you hear me?
Yes, I can hear you.
Thank you for all these talks. I really enjoyed all of them. Now, most of our young ophthalmologists, unfortunately, their presentation was a case presentation, except for Dr. Nuran. Now, I was hoping to see more of studies rather than case presentations, because this is what really matters. Case reports are very simple, very easy, although whoever presented really nice cases which we really can learn from. But I encourage in future, but if you want to go into an international competitions, that obviously case reports will not go. You have to present actual research proposals or research work, like the one presented by Dr. Nuran, for example, which is very, very interesting. I really encourage her for the result. But the rest of the talks are very good. And good luck for Dr. Anwar. I hope we will be able to hear her talk again. Thank you.
Thank you. Thank you, Dr. Amal. And please, Dr. Hisham Khattab. Dr. Hisham?
Yes, Dr. Heba.
Good evening. We're very happy having you today.
Yes.
Do you have any comments on any of the presentations?
All the speakers are eminent and speak very interesting talks, and speaking as very, very, very kindly and nicely. The cases are so good, and I agree with Professor Dr. Amal for the case presentation. especially that of the granuloma. And we are speaking for anything related to the pediatric ophthalmology and strabismus, not related especially to a case report, because the case report is not done and diagnosed and treated by the young ophthalmologist. He has to study more things and other team working for this special cases. Otherwise, the are very good.
Thanks, Dr. Hisham. Dr. Hatem, I kept you at the end because I expect you can you would like to comment on the glaucoma case or the ROP case or other specialties rather than the strabismus. Dr. Hatem?
Yes. Thank you, Heba.
Thanks for having you today.
I have thank you. I have some comments.
Yes, go ahead.
First, the case of Nawar, I was interested to complete it till the end because it's really interesting to have a hypo DVD, which is extremely uncommon, as you know. The other question to Nader, I think he missed one of the causes in the differential diagnosis that he should have put, which is megalocornea. And this is one of the nearest differential diagnosis to his case because the cornea was clear. It's very hard to find congenital glaucoma with a clear cornea, but it's very common to have a megalocornea with a clear cornea. The last comment to Sra, I'll give you a very funny dictum to learn. Instead of saying superiors gives to the contralateral and inferiors gives to the ipsilateral, you can say S for S and I for I. S, superior rectus and superior oblique for the sound side. And the inferiors, the I's for the involved side. S for S and I for I. Thank you.
Thanks, Dr. Hatem, and thanks for the previous 5 speakers. Thank you so much for sticking to your time, and I hope the next 5 speakers to stick to their time as well. And I ask all the previous speakers to keep around, don't go anyway, because we might have another discussion at the end of the free talk session. And now I invite my co-moderator, Dr. Sameh Galal, to moderate the other 5 speakers, and we will give Dr. Nawar another chance if she had her IT technical problems fixed. Thank you. Dr. Sameh, go ahead.
Before we start, can we call Dr. Nader if he's ready around to discuss with him his case, because Dr. Hatem aroused a very nice issue to discuss about. So if Dr. Nader is around.
Yes, I'm here.
Yeah, can you comment, please?
Well, yes, Dr. Hatem is totally right. I didn't say it in the words, but I put 2 cases of glaucoma with megalocornea here as our center. And I said that we should not miss the primary congenital glaucoma, and I showed the 2 pictures of megalocornea. I didn't say it by the words, but I totally agree with my dear professor, Dr. Hatem.
Before we start our second part of the 3 talks, I'd like to call Dr. Nawar Shahada if she's ready with her talk and connectivity. She can be ready by the end of this session if she can present her talk. But till that time, we can now call Dr. Abdi Rislan from Morocco to present her talk. Can you please share your screen to present your...
Yes, I'm ready, doctor. Sorry for the connection loss.
Thank you. Okay, no problem.
Do you hear me, please?
Yes, we hear you very well.
Yes, I can start.
Still, we can't see your presentation. So, yeah, now ready. Yes, you can start.
Okay. So, dear sir, I have the pleasure to present this case about an unusual ocular manifestations of silent sinus syndrome. So this syndrome is a rare disorder characterized by ophthalmos hypotropia, increased ipsilateral orbital volume secondary to maxillary sinus atelectasis. The classical treatment aims to restore normal sinus aeration and to correct ophthalmos and hypotropia with an orbital implant. The case is about an 8-year-old boy who presents exotropia and amblyopia 2 years, which was discontinued 3 years ago. The treatment was started on glasses. There is also no history of trauma or surgery. The ophthalmological exam revealed visual acuity in the right eye was conserved and at 1/10 in the left eye that doesn't change after correction under cycloplegic refraction. There was also far and near left exotropia and torticollis. The Krinsky test shows an concomitance at distance right eye fixating, exotropia of 35 prism diopters, and left hypotropia of 4 prism diopters with left eye fixating, and exotropia of 50 at near distance right eye fixating, exotropia of 30 prism diopters, and left hypotropia of 6 prism diopter with the left eye fixating, and exotropia of 50 prism diopters and left hypotropia of 6 prism diopters. So all the left extraocular muscles was an underaction except of the lateral rectus muscle. It seems an adduction deficit. So this picture shows the facial asymmetry in ophthalmos and hypotropia on the left eye and gaze restriction. This picture shows that there is no adduction deficit in adductions. Upper eyelid did not follow the left eye when it moved in a downward position. There was also a manifest constant pendular nystagmus, low amplitude and frequency, no null point observed in all gaze positions with upper eyelid fasciculation. In an attempt to open the eyes, they converged. The orbital MRI scan showed the anomalous left maxillary sinus featuring small size associated with elevation of its floor and lowering of orbital floor. A slight deviation was also noted of the nasal septum of the affected side and lateralization of the uncinate process and left middle turbinate. A coronal section of MRI showed inferior displacement of extraocular muscles positioning, mainly the inferior rectus. So the patient was treated with glasses and referred to otorhinolaryngology department for endoscopic maxillary enterostomy. After 12 months of formal evaluation, visual acuity and ocular motility were unchanged. So this syndrome, its exact pathogenetic mechanism is not clear. There is some hypothesis like chronic obstructive sinusitis coexisted with the primary condition of sinus hypoplasia and infundibular obstruction as a probable pathogenetic event leading to sinus hypoventilation and development of negative pressure leading to slow maxillary sinus atelectasis. This case presents some infrequent features associated with silent sinus syndrome. The occurrence of symptoms is in this age group is unusual, although diplopia and gaze restriction are seen in some cases. Its presentation is unusual, mainly in this age range. The motility issues is due to a mechanical restriction as showed by MRI scan and in the previous studies. The treatment of this syndrome typically consists in functional endoscopic surgery to remove the obstruction and restore positive pressure. Orbital floor lifting and reconstruction may be performed during the same session or at the late date.
We have only 30 seconds remaining.
What?
30 seconds remaining.
Okay, so in the conclusion, silent sinus syndrome is a rare entity of spontaneous progressive asymptomatic collapses of the maxillary sinus. It describes a constellation of ocular and nasal findings, so both otorhinolaryngologists and ophthalmologists should be familiar with it. Thank you.
Thank you very much, Dr. Abdi. And now I am calling Dr. Dua Ashraf to upload her presentation. And I'm asking the audience to vote for Dr. Abdul Islam for this nice presentation.
Can I start now?
Just a few seconds till the end of the vote.
Okay.
Okay, nice results for presentation of Dr. Abdul Islam. Thank you very much. And now let's call Dr. Dua Ashraf from Bani Suef Hospital to present her presentation. Please start.
Okay. Hello, everybody. I'm very glad to be here in the first EAPOS Young Ophthalmological webinar. Today I will talk about a small study we done here in Bani Suef about a new trend or a hidden trend in children called video vision syndrome. What is video vision syndrome? It's a group of visual and eye symptoms caused by prolonged new work related to computer use. The main symptoms are asinopic features, asinopic eye manifestation in the form of headache, eye aches, blurred vision, diplopia, irritation, and blurring. Why video vision syndrome? Why the cause? What is the cause of it? The extra strain needed from the eye to focus on the pixel composition of the digital screens is a key factor. Environmental circumstances like wrong position, wrong work distance, bad lighting, and screen glare. And of course, above all, uncorrected visual or uncorrected error vision. And the children join the party. Children and video vision syndrome are a hidden trend, as the children usually ignore persistent eye problem for continuing joyful playing. Even their high adaptability make them tolerate the glare. Due to early development of stereopsis and binocularity, the occurrence of any amblyopia, even mild, where the stereo defect could be permanent. We gathered a sample of 100 children aged from 3 to 10 years. A questionnaire were given to the caregiver, evaluation the duration using computer games and video games, even any electronic screens, and the occurrence of ocular asinopic features. We did all the comprehensive ophthalmological examination, visual acuity, cerebroplagic refraction, slit lamp, and fundus examination. We classified the results into two main groups. First group, the computer video game group, which is spending more than 3 minutes of playing on the computer video games, and the passive electronic exposure group with use any electronic device below the 30 minutes and any duration less than 3 minutes from even electronic exposure or computer video game were put in the group, the control group. We found significant relation between prolonged computer game exposure and the following: some asinopic feature in form of ocular pain, redness, and eyelid tips, and secondly, astigmatism. While in the passive groups mean it's only exposure to a screen, electronic screen like TV or YouTube, not engaging in any activity or active activity. Only ocular redness and astigmatism were significant. And these figures represent our study results. Our limitation in our study, relatively small sample, overestimation of the symptom from the parents, of course, Egyptian parents, and the need of follow-up after reduction of the exposure level to depend the results, even the manifestation will decrease or still the same. Our conclusion: video game syndrome was related previously to extensive usage of computer among adults. Now its prevalence in child is rising. All video vision syndrome features are not well defined, although in our study we managed to get specific relation between prolonged computer exposure and asinopic feature, especially ocular pain, redness, and eyelid tics. We give the parent instruction about the right environmental precautions during video gaming and the recommended time of usage. Thank you.
Thank you very much, Dr. Dua, and really another thanks for finishing 1 minute, treatment before the time. So very nice presentation. Now we are waiting for the voting for Dr. Dua. Then our next speaker, Dr. Smita Kapoor, is uploading her presentation. Okay, excellent, 34%, mashallah, very nice results. Thank you very much, Dr. Dua. And now let's call Dr. Smita Kapoor for her talk. Dr. Smita, are you ready? Dr. Smita Kapoor? Dr. Smita, if she's muted, please, Mr. Mohab وشادي لو في
دكتور سامح هي فاتحه الكاميرا وفاتحه البرزنتيشن بتاعتها وهي موجوده معانا.
Okay. Dr. Smita Kapoor, can you hear our voice?
We can't hear you, Dr. Smita.
Can you hear me?
Yes, now it's fine. We can hear and see you. Please start.
Can I start now?
Yes, please.
Okay. I am Dr. Smita Kapoor from India, and I'll be presenting a unique way of treating third nerve palsy with aberrant regeneration. My slides are not working.
Yeah, click on slide, please.
Okay. So before starting, I'll be presenting the patient's consent. A 38-year-old female suffered from head injury in a road traffic accident 3 years before she presented to us. She was unconscious for 20 days. Her CT scan showed a subarachnoid hemorrhage. On regaining consciousness, she was unable to open her left eye. This improved over a few months when she started noticing double vision and outward deviation of the left eye. So when she presented to us, her complaints were drooping of the left upper lid, binocular diplopia, and outward deviation of the left eye. Her visual acuity in both the eyes was 20/20, and intraocular pressures were normal. Her left eye showed a moderate doses of 3 mm with poor levator function. There was no lag of ophthalmos. Bell's phenomena was poor. Marcus-Gunn jaw winking was absent. Hirschberg test showed 15-degree exotropia and mild hypotropia in the left eye. Cover test revealed secondary deviation more than the primary deviation. Extraocular motility was restricted in all the up gazes, down gazes, and on dextroversion. Abduction and intorsion were present. When we asked her to adduct the left eye, there was an improvement in the palpebral fissure width, which is reverse of what is seen in Duane's retraction syndrome, hence the name inverse Duane sign. And on asking her to look down, there was a lid lag, which is seen in thyroid eye disease known as von Graff's sign, hence the name pseudo-von Graff's sign. Other signs of aberrant regeneration are abnormal globe retraction on attempted vertical movements, pupillary constriction on attempted adduction, which is known as pseudo-Argyll-Robinson pupil, and ipsilateral adduction on attempted vertical movements. On doing a Krimsky test, the patient was able to fuse with 35 prism diopters base in and 5 prism diopters base up in the primary gaze. The right eye pupil was 2 mm and left eye pupil was 5 mm, suggestive of anisocoria. Both the fundus examinations were normal. Thus, a diagnosis of left-sided pupil involving traumatic third nerve palsy with aberrant regeneration was made. So the conventional treatment in such cases would be to operate the affected eye by doing a lateral rectus recession and medial rectus resection, followed by a ptosis correction. However, the problems with this are that it is a two-step procedure which is cumbersome. Resection is not very useful in such cases because the nerve to medial rectus is already compromised. And any ptosis procedure carries the risk of corneal exposure because of poor Bell's phenomena. So we operated the right eye by doing a lateral rectus recession of 7 mm, medial rectus resection of 5 mm, and shifting the muscles half muscle downshift. This is the first day post-operative picture with symmetrical lids. The patient was diplopia free in primary gaze. She was orthophoric. She has been the same for a period of 1 year now. So aberrant regeneration is the misdirection of regenerating axons which are seen after traumatic or compressive lesions of the nerve. This leads to synergistic movements of the eyelid with eye movements. The first report of a similar case was published in 1980, where the normal eye was operated and improvement in both strabismus and ptosis was noted. Similar cases have been reported with adjustable sutures as well. So how does this procedure work? Weakening of the contralateral lateral rectus, according to Herring's law, will lead to an increased innervation to the affected medial rectus as well as the LPS, and this will alleviate the ptosis. And according to Sherrington's law, there will be a decreased innervation to the lateral rectus of the affected side, reducing the chance of contracture. This technique also creates a fixation duress on its yoke muscle, that is the medial rectus of the affected eye, thus keeping the eye in an adducted position when the normal eye fixates. Thus, in conclusion, I would like to say that always look for signs of aberrant regeneration in third nerve palsy, because in such cases, operating on the contralateral unaffected eye can be a promising option to correct both the strabismus as well as the ptosis in a single-step procedure. However, the only problem is counseling the patient regarding the decision of operating the better eye, and that can be a challenging process. Thank you for your attention.
Thank you very much, Dr. Smita Kapoor, for your nice presentation. In our proposal, it was expected to receive the presentation of Dr. Yasmin Mekdad, but she had an emergency. So I'm asking the audience, please, to vote for Dr. Smita Kapoor. And I'm calling Dr. Amr Magdi if he's ready with his presentation to upload his talk. Dr. Amr, still we can't hear your voice well. So if you can fix it, please do. Wow, excellent results for Dr. Smita Kapoor. 63% of the audience voted by excellent. Very nice presentation, really. And now we are hoping to hear the voice of Dr. Amr. Dr. Amr, can you try again, please?
Dr. Amr, can you take off your earphone? Try now, please.
No, still we can't hear your voice.
Can we ask Dr. Nawar if she is ready, Dr.
She's
Sameh?
ready with her presentation, yes. If Dr. Nawar is with us, can you upload your presentation?
Yes, I'm ready.
Okay. Dr. Amr, please try to fix your voice problem till we receive the presentation of Dr. Nawar.
Would you like me to restart or continue?
Yes, please.
Restart from the beginning, please.
Okay. Okay, we have a case report about hypoxic dissociated vertical deviation. We first want to say that the DVD is characterized by vertical drift of the non-fixating eye, or when we cover this eye, upward drift are common and usually accompany congenital esotropia and latent nystagmus, but downward drift is very rare and only 10 cases have been reported in literature. This table shows the reported cases and their clinical characteristic. We can see here that all the cases are unilateral except one cases, and most of the cases have a very low visual acuity in the hypodeviated eye. The last case report I have found it in 2013 for a 25-year-old female with unilateral esotropia, hypotropia, and downward drift in her left eye. Now our case is about 4-year-old girl presented with intermittent exotropia of both eye since the age of 7 months without any prior therapy. Cyclorefraction was presented here, and she has mild hypometropic refractive error. This table shows the measurement of the exodeviation. For near is about 30 prism diopter, and for far is about 50 prism diopter. She has a significant V pattern with bilateral inferior oblique overaction secondary to bilateral superior oblique underaction. The fixating eye is alternative, and the exodeviation is very variable because of the DHG in both eyes. She has manifest latent nystagmus in both eyes, which significantly decrease in down gaze, and so that she has anomalous head position by chin up to inhibit both nystagmus and exotropia. She had hypo-DVD, but only when we cover the eye in both eyes also. Now we can see the patient, this video on the primary position. We can see the hypo-DVD with the exotropia and the latent nystagmus. In down gaze, the exotropia and nystagmus is significantly decreased. And in up gaze, the exotropia is increased. Let's compare between the other cases that reported in literature and our cases. All the reported cases, except one, were unilateral, but our case is bilateral. The most prominent feature of all cases was the vision deficit in the hypodeviated eye. Our girl isn't cooperating for visual acuity, but alternative fixation implies the presence of close VA in the both eyes. All cases, but last one has acquired etiology, but our case is congenital. She has not, other cases has not accompanied by latent nystagmus, but our case accompanied by latent nystagmus, which is just like hypertropic DVD. At the end, we need to answer many questions. What is the etiology, the exact etiology of hypo-DVD, and what is the best surgery technique to treat hypo-DVD? And finally, what do you think we can do for this patient, or what we did for it? I will show you a video for the patient after the surgery, after a few months. You can see here that the exotropia is disappeared, but still hypo-DVD, especially in the left eye, if you see here. Thank you. Thank you for listening.
Thank you, Dr. Nawar, for this nice presentation. We're really lucky to have you again. And I'm asking the audience to wait for Dr. Nawar. And like an April, the final call for Dr. Am to try. Can you please try the voice connectivity again, please? Still, we can. So we are sorry not having your presentation, Dr. Am. We hope to see you in another meeting. Thank you very much for sharing with us. And now to see the results of waiting for nice results.
I would like to highlight for the judges that Dr. Nawar was supposed to be the second speaker. So you'll find her in the list in the second place.
Yes, second one from the start. And now I am moving back to the discussion panel, to our prestigious board. And let's start with Dr. Amal. Do you have any special comments or last 4 presentations?
Can you see me?
Yeah, we hear and see you.
Okay. My first comment for Dr. Sameh Galal, I'd like to congratulate her on the result that she got. And of course, R&R is one of the methods that we use in the management of third nerve palsy. It's not the only option, but I congratulate them on the result of using the sound eye for management of the third nerve on the other one. For Dua Ashraf, on the result on the computer games, it's very interesting study really, especially with the popularity of the games among our kids. Of course, this is interesting. It's, however, my reservation is that it was the notes or the observation noted on a 30 minutes playing time, which is really very short. I think most of our children, once they start playing the video games, it will be hours and hours before they start. We will feel that they have spent so much time. So I wish that they have made their observation on our children with a longer time. And of course, this was a questionnaire, and the questionnaire to families is always questionable, of a questionable reliability. So I wouldn't. However, I congratulate her on these results. Thank you.
May I comment, please, Doctor?
Yes, please do.
We considered the threshold for putting anyone in the active group is above 30 minutes. So 2 hours is still with us. Even 5 or even the whole day. We have 3 person or 4 person, more than 20 hours per day. So very nice point, and we had it. Unfortunately, it's still a small sample, only 100 patients.
Yes.
Thank you, Dr. Dua. Thank you very much, Dr. Amal. And now moving to Dr. Dalal.
Yes, I have 2 comments.
Yes, please.
I have one comment also for Dr. First, I like to congratulate all of the speakers, really. But I have the comment for Dr. Dua for the video games, because this is an observation that we are always observing, that accommodative esotropy especially is increasing with those who are playing in video games and in mobile, and we tell them not to play except a small amount of time, but we have no study done. So I appreciate really to start to investigate this and its effect on, especially on accommodative esotropia. Okay, and also for Dr. Sinta, I want something to tell the parents. When we will operate on the healthy eye in cases of third nerve, I want first of all to tell the parents and to be clear with them that the affected eye, for example, is the left eye, but we are deciding to operate on the other eye for special scientific criteria. So not perhaps the patient is going to another doctor and he is telling her this is a mistake and your affected eye is the other one, to be clear and to justify before operating. Okay, and also the last comment for Dr. Nawar, the DVD, to show it clearly, it is best by using the semi-translucent cover. It would be clearer even in the presentation to put a semi-translucent cover in front of the affected eye, and the deviation will be very well clearly shown to others. And thank you for all.
Thank you very much, Dr. Dalal. Dr. Hisham, do you have any comments for these presentations?
First of all, I want to thank all the speakers, are very eminent, especially and also about the computer games and video games for children. It is very difficult to control them. So you have to study the parents how to manage about this, for the distance between the child eyes and the computer or tab and something, and also with using the light turned on all the time, not in a dark room or abnormal position. Otherwise, we cannot control the children and we cannot control it at all. Otherwise, I want to thank all the speakers, are very, very, very good speakers. Yeah.
Thank you very much, Dr. Hisham. And Dr. Hatem, usually before asking you, I'm expecting all the time having precious points to comment in a different way. So Dr. Hatem Saeed, do you have any comments on these topics discussed?
Of course I have.
As expected.
First, I want to ask Dr. Abdi about the motility defects in her case, how this can be corrected with surgery on the sinus. How can reforming the sinus correct such an extraocular muscle defect? My second question is for Dr. Dua. I don't think I really correlated well the presence of astigmatism with the new work. Is this just a coincidence, or there is a cause-result relation? And the last question to Dr. Smitha, about the surgery on the sound eye in cases of third nerve, aberrant regeneration of third nerve. We noticed that the affected eye is slightly hypotropic, and part of the ptosis might be due to this hypotropia. How would this be treated with surgery on the sound eye? And the other thing that I got that putting the affected eye in adduction will correct the ptosis using the advantages of this apparent regeneration. What about inducing ptosis in the sound eye by shifting the muscles down? How do you calculate both measurements together? Correcting the ptosis in the affected eye and creating a slight ptosis in the unaffected eye.
Okay, let's start.
Other than this, there is very good discussion.
Okay, thank you very much, Dr. Hatem. Let's start by Dr. Abdi. Do you have any comments on Dr. Hatem's question?
Yes, so usually after endoscopic maxillary antrostomy, the oculomotility disorders was arbitrarily ameliorates after education, but in our case, because of the ocular motility disorders was from birth of the child, so it was unchanged in our case.
Okay. So,
It's a coincidence. 1 year, we do the study again and compare between the two results to discuss which is it a result. Can we put the astigmatism in direct relation with the new work or not?
Okay, thank you very much, Dr. Dua. And finally, we have Dr. Smita Kapoor.
Yeah, thank you for the question. So I think the ptosis was true ptosis because when we made the patient fix with the left eye, the ptosis did not improve. So because it was true ptosis, it was basically the aberrant regeneration that led to the improvement of the ptosis after surgery. But your question may be right. I'm not sure if it could be the other way around.
Yeah, what about shifting the muscles down in the other eye? Would this affect the lid position of the right eye?
I don't think downshift affects the position so much.
Okay, thank you.
Okay, thank you very much, Dr. Smita. And I'd like, by the end of this section, to thank very much our prestigious, exceptional board of discussants and judges, Dr. Amal Alhemidan, Dr. Dalal Shawky, Dr. Hisham Khattab, and Dr. Hatem Saeed. Thank you very much for your precious time and for sharing with us your valuable knowledge. Thank you very much. And by this end, I'd like to conclude this first part of our webinar today, giving the talk to my dear friend, Dr. Ayman, to start the second part. Thank you very much for the discussants and for the sharing doctors with free talk.
Thank you so much.
Thank you so much.
Thank you, Sam. Again, I would like to really, from my heart, thank our discussants, our the discussants and judges for their efforts, concentration, a valuable discussion. Thank you, Dr. Amal. Thank you, Dr. Dalal, Dr. Hatem, Dr. Hisham. Thank you very much. You did a very good job, and the discussion was very rich. Thank you very much. Thank you for this. And waiting for the scores to be sent privately, and then we will collect the score and announce the winner at the end of this session. Thank you for the discussion. And again, I would like to thank actually all the speakers. They were amazing. Thank you very much. Actually, the level of this of the speakers were really higher than what I expected. This is very, very interesting talks. I learned a lot from these discussions. I'm sorry for this interruption. Dr. Yasmin had apologized. Dr. Am had a short notice to replace here. But again, we had a average nine talks. We really did a good job, and would like to apologize for the 9 speakers. We put them under stress. You have to stop after 5 minutes. We really put many restrictions, but you really did a good job. You trained a lot. Thank you very much. Now, it's time for the next section. Next section, we're very excited for the next section. The next section will be such a very, very exciting part. In the next section, we start the competition, the young ophthalmologist competition. For the first time online. For the first time online, we are going to start for the competition. The competition between teams. We have requested, we had 8 teams who applied, so 4 will be with us in this evening and 4 will be on the next event. So because we split the young ophthalmology into 2 events, this is the first one, will be the second one. We will announce for you the date later. First of all, I would like to thank our professors who put the questions for this competition. Professor Dr. Adel Alhemidan, Professor of Ophthalmology Research Institute, Professor Ibrahim Al-Adawi, Professor of Ophthalmology at Mansour University, Professor Ahmed Awadin from Cairo University, and General Secretary of the EAPOS, Professor Yasmin Saeed, Professor of Ophthalmology at University, and the EAPOS board member. I'd like to thank them. They did a very good job in putting the questions for this competition. We have 4 teams. The 4 teams, they are the RPC Warriors from India, the Lazy Eye Hitters from Egypt and United Kingdom, Specialized Center for Strabismus team from Syria, and Brown team from Egypt. Let's first say the rules, the competition rules. Each team will be asked 5 questions. There will be 1 question on these topics, on each topic. Basic strabismus question, advanced strabismus, pediatric anterior segment question, pediatric posterior segment question, neuro-ophthalmology and oculoplasty question. I know that all the teams has been trained for this. We have met 2 days ago, and all the players, they know the competition rules very much. But I'm just reminding you, and for the audience to be aware of the rules that we are going to use. Each correct answer, you will have 1 mark in the score, and wrong answer will have 0. Each team will have 40 seconds to think, discuss together, the team members to discuss together, and give us the answer. The 40 seconds will start after reading the question. Again, it's after reading the question. So reading the question, then we will start 40 seconds. We'll give you an announcement 10 seconds before the end. So after having the 30 seconds, you will have an announcement. You will have some red line. We will show it to you in the sample, moving until it ends. This means the 40 seconds. At that moment, the team leader should give us the final answer. If you couldn't have the 40 seconds passed and you didn't give an answer, you will lose the mark for this question. You have 2 help methods. وسيلتين مساعدتين. You have 2 help methods. The first is joker. You will choose the joker to be used once in the match. The joker should be specified before reading the question. Before the question, you will specify what use the joker. If you got the correct answer, you will get 2 instead of 1. But if you had the wrong answer, it will be 0 at the end. The other help method is the audience help. رأي الجمهور. That's very important. The audience help. For every team has the chance that once request what's called the audience help to choose, but it's be used only in one once per match only. Okay, so you have 2 methods. 1 after the question, the joker, you have once, and the audience help. If you requested the audience help, we'll have a vote. And please, I'm asking all the audience to be concentrating with us, because they will share in the answer and they will choose to help the team in answering. At the end of the match, if it happened that 2 teams got an equal mark, we'll go for the penalties. We will have 1 question for each team. 1 question for each team. If 1 answered and 1 didn't answer, the answer 1 will be the winner. If they still draw, both answered or both didn't answer, we will go for the audience to help us to choose which team wins. We'll have an audience vote, and the audience will choose which team wins the match. And for the players, we have stressed on this in our meeting 2 days ago, but again, I have to stress it. The internet connection is your responsibility to secure. And again, your camera should be on during the whole match. All the cameras should be on, should be seeing all of you. If by any time a camera has been closed, that member will be muted, so will not be able to share with the other team members. But the other, if this happened, or any other, one of the team member had any technical problem and lost connection, we will continue the match with the current players, even one player only. Okay. Now, let me introduce the teams. The first team is the RPC Warriors from India. Dr. Jonjan Saluja, Dr. Asha Samadni, Dr. Surab Verma, Dr. Kartika Baskaran. I wish I am pronouncing the names right. Welcome for the RPC Warriors. The second team is called Lazy Eye Hitters. Dr. Dua Gamal Al-Fadali, she's Egyptian working in Morfields Eye Hospital. Dr. Joyce Shan from Morfields Eye Hospital. Dr. Dua Ashraf, Bani Suef, just presented her talk now. Dr. Asma Fuad from Egypt. The third team, Specialized Center for Strabismus team. The team is from Syria. Dr. Wael Al-Hamuda, Dr. Wala Al-Sa'a, Dr. Nawar Al-Shuhadi, Dr. Ala Al-Awadi, and Dr. Lama Shliha. They will have to choose 4 of the 5 to be in the team. And the fourth team is the brown team. Dr. Muhammad Osama Al-Abbasi, originally from the Rio and now in Germany. Dr. Riham Fawzi Shirbini, Dr. Riham Samir Ataya, Dr. Isra Muhammad Abdelmenem Al-Khuli. Welcome, all 4 teams, and be ready. Now, the point is, which team will start? We will have a poll for this, okay? We have to make it. لازم نعمل قرعة مين هيبدأ مين. So I'm asking the audience now. We'll present a vote now. You vote which team you would like to see in the first match, and the highest score, the teams with the highest 2 scores will be the one facing each other in the first match. And after the first match will finish, we'll have the other 2 teams to meet in the second match. Please, audience, vote for us. Okay, so the highest scores were brown team. Let's see. It's brown team and the Lazy Eye Hitter. Okay, that's great. So the first match will be brown, this team, against Lazy Eye Hitters, this team. So both teams, be ready. So I'm asking if any other speaker or our valuable professors of discussants are still opening the cameras, please just, I'm asking them to close the camera to give a chance for the teams to open their cameras, so for all of us can see the team members, both team members. Okay. Yeah, that's great. Let me stop the share. So the only 2 teams now should be with us, brown and Lazy Eye Hitter. So just to make sure that everyone is there, let's start the first team, brown. Please say hi for one by one. Dr. Muhammad Al-Abbasi, are you there?
Hi.
Welcome. Reminding you, all of you should be opening the cameras. That's very important. Dr. Riham Fawzi?
Yes, I'm here. I'm here.
Welcome. Dr. Riham Samir?
Yes, I am here.
Hatem Saeed?
Yes, I am here.
Okay, great. Dr. Isra Al-Khuli?
Yes, I'm here.
Yeah. Welcome. Are you ready for the questions?
Yes.
Right, okay, next team. The other team is lazy eye hitters. Dr. Dua Gamal Al-Fadali.
Yeah, I'm here.
Again.
Yes,
Dua,
I'm here.
welcome. Yes, I saw you. Dr. Joyce Chen.
Yes, I'm here.
Welcome, Dr. Joyce. Ashraf.
Yeah, I'm here.
Welcome again. Dr. Asma Fouad.
Yes, I am here.
I'm safe. Again. Yeah, Dr. Asma, I saw you. Remember,
yes,
cameras, I will remind you something. The cameras should be on during the whole match. When the one team asks, if a question is for the brown team, the lazy eye hitter will just mute their mics, but they keep the camera on. Okay? And when the question is for the lazy eye hitters, the brown will should stop the mic only, but keep the camera on. Is that clear?
Dr. Ayman, can we activate the gallery view? I can't see my members of my team.
It's from you, from your end.
I think by sharing
help her in this.
By sharing the screen, this option is hidden.
Who is with us, Mr. Muhammad or Shari?
No, you are not sharing your screen now. You can go up on Zoom. You will find speaker view or gallery view. Click on gallery view.
Yeah. This option is activated only without screen sharing. Anyone share his screen? This
you will not share your screen. You are not sharing your screen.
You will find 3 buttons above your camera. Click on second one or third one. You will find all of the speakers.
Okay. Okay, so now I'll give you one sample question just for the players and for the audience to understand how things will go on. Okay. What you, Muhammad, with us?
We are losing one of brown team.
Who?
Okay.
Who did we lose?
I think Riham Sherbini.
Yes.
Okay. As I mentioned, we have to.
It will not be allowed to back again.
Why?
You mentioned like this, Dr. Ayman. If it go out while we are talking about questions, it will not allow to.
I haven't started yet. She can come in.
Yeah. If she come while we start.
Yeah. No, please. If she's in, if she's back, let her in, please. There's no problem in this. Let her in. If she came anyway, let her in. Okay. Okay. So let's have this trial question. What are you going to be presented? A picture like this. Can you all see the share screen?
Yes.
Yeah.
Okay. These are the 5 categories. All of you will be asked one question in these 5 categories. Okay. You have the opportunity. You have the opportunity to choose which one of this from 1 to 7. The number you will see, then we click it on it, and then you will have the question. So if you have an easy question or difficult question, you are the one who choose the number. Is that clear? Okay. Yeah. Let's have the trial question. Let's choose the first one in the first Q1. It's just a trial. It's not a true question. It's just a sample. Yes, you will be faced by this, and I will start reading the question. Okay, a 2-year-old child presents with intermittent exotropia. All of the following could describe her condition except number A, suppression, number B, excellent stereopsis, number C, large convergent amplitude, number D, amblyopia. From this point, you have 40 seconds to think. So now we'll start counting down 40 seconds. After 30 seconds, can you see this red line? The red line will start. It takes 10 seconds to close. When the rectangle is closed, it's time to give the answer. This means 40 seconds had left. At that moment, the team leader has to give us an answer. If the team leader is disconnected, another team member should give us an answer. If we didn't receive an answer, unfortunately, you lose the mark of this question. Okay, so let's say you choose number B. So now the answer is number B. You answered number B. The next point is what is it correct or not correct? As mentioned, it's get red, so it means that it is an incorrect answer. Okay? If it is correct, you will find it to be green. Okay? Let's get back to the main screen. Let's get back to the main screen, please. Okay, so relax, all of you. Any question before we start?
No.
The chat, we should close the chat. We will disable the chat.
Close it, Dr. Ayman.
Sorry?
We close it, Dr. Ayman.
Okay, the chat is good. So you don't have any external help unless audience response once. Okay, relax and get ready. The one who got high score was Brown. So Brown will be the first one to be asked. Ready to start?
Yes.
Okay. The first question for Brown will be, again, the first question is basic strabismus. You will choose any number from 2 to 7 because you used 1. Please, Dr. Mohammed.
I will choose number 2.
Number 2. Okay. So please, let's see the question number 2. Okay, the question is, which of the following is false regarding the use of atropine in treatment of mild to moderate amblyopia? Number 1, atropine is as effective as 2 hours daily patching in final visual outcome, but the improvement is slower in atropine. B, weekend atropine is as effective as daily atropine. C, adding a plano lens to the hyperopic amblyopic eye will significantly improve the visual outcome. D, no bifocal is needed for the normal eye, even if atropine is used for more than a month. You have 40 seconds from now to communicate with each other and give me an answer.
انا رايي ان انا اختار دي، بس هتناقش مع زمايلي. ريهام ريهام رايكم ايه؟ دي برضه زيي ولا ريهام واسراء؟
رأيي دي زي حضرتك.
دي اوكي، خلاص انا اختار دي.
جواب نهائي. Final.
جواب نهائي. Final.
So you will choose B or D?
D. D. D.
D. It's
D.
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 It's D. رابع واحدة. Okay, so they choose D, which is no bifocal is needed for the normal eye, even if atropine is used for more than a month. And the question was, which of the following is false regarding? So you believe that this is a false answer. Are you sure about this?
We think so.
We didn't think that weekend atropine can be wrongly to be as effective as daily atropine. You don't think so?
No.
Okay, let's see the answer. Show us, please. Oh.
Okay.
Okay. Let's choose the correct. Let's see the correct answer. Dr. Mr. So, answer. C, yes, thank you. It's C. Adding a plano lens to the hyperopic eye. Actually, we don't use a plano lens to the hyperopic eye. The hyperopic and amblyoptic eye, we don't use a plano lens for it. So this was 1. So unfortunately, you don't have a mark in this. Okay, best of luck in the next 4 questions. Next team. Now, the lazy eye hitters.
Yeah.
Get ready for your first question, which will be on basic strabismus. And again, I'm asking the Brown team, keep your cameras on. Keep your cameras on. Just we will mute the mics for you. Okay, so lazy eye hitter. You are ready?
Yeah.
Okay, lazy eye hitter. The team leader is Dr. Dua Fadali.
Yeah, I'm here.
Okay, welcome, Dr. Dua.
Thank
so
you.
You have to choose which one. Okay, you will choose 1. We choose 2. So use from others up to 7. which question you would be interested to be asked?
Question 5.
Do you think it will be easier? Which two? Okay, let's see question number 5. Which of the following is false regarding monofixation syndrome? Concentrate on this, the question about what's false. Amblyopia is an uncommon finding. It's associated with a small high heterotropia, which is more commonly an ET rather than an exotropia. Most patients with monofixation syndrome have gross stereopsis, about 200 to 3,000 seconds of arc. Most of patients with monofixation syndrome have gross stereopsis.
Okay. I would go for A. What's your opinion?
A.
What's your opinion, Joyce? Okay, yeah. Dua, Asma, are you agreeing with me for A?
A.
A as well? Okay, we choose A.
Dr. Already, but that's very smart of you. That's very smart of you.
Actually, this is a Joyce idea.
Yeah, that's Joyce's idea. We were afraid of some internet glitches, so we chose to like present paper. I know it's very
It's a very smart idea. Okay, so an uncommon finding. Wow. Do you think this false?
Yeah, I think to some extent they do have some form of amblyopia and reduced central stereopsis. However, the peripheral stereopsis is present there in monofixation syndrome.
And Ashraf, do you agree for her, but with this?
Actually, now I have a mental block, so I will go with them.
Okay, let's see the answer. Let's see the correct. Wow. So the first mark. Thank you. That's the first one. So that's the first point for us. Okay, let's shift to the second question. Brown team, get ready. You lost one question. You don't want to lose the second question. Open your mics. Make sure
I would like to ask my team if we can choose a joker help to this question.
Yes,
wow.
I agree. Sorry.
The advanced Christmas. Wow. Quite a difficult question.
Maybe you have luck.
Hey, you agree?
So,
the team has agreed for this.
Okay.
Okay, go ahead.
Okay. So for the brown team, the second question will be joker question, which means if they answer correctly, they will have 2 points, and they will exceed the lazy eye hitter team. That's interesting. Okay.
We will choose
so
question number 5. Sorry.
Yeah. Okay. Question number 4 actually has a technical error. That's why
number 5. Number 5.
You choose number 5. Okay. Question number 5. Get ready. The question is, which of the following is not true? Again, the question is about what is not true regarding the trend towards emmetropia in the pediatric population. Emmetropization occurs for myopia, hyperopia, and astigmatism. The main changes happen in the first 2 years of life. It can still occur after the 3rd year of life. It happens equally in seeing and non-seeing eyes. Which of the following is not true?
ايه رأيكم انا بختار بي.
Yes, I agree. B.
رأي ريهام وإسراء.
Which is not true?
B.
طيب جواب نهائي.
اوكي هنختار
is
B.
ثاني واحدة.
بالظبط.
Okay. We highlighted 2. So you choose that the main changes happen in the first 2 years. The following is not true. Do you think that's not true? Okay. So you think the main change happened in the first year, first 10 years? You don't agree about the first 2 years?
No.
دكتور إسراء رأيك
I'll
إيه؟
go with B.
طيب يعني يعني you'll get 2 marks and get the benefit of a joker, or you lost the joker. Let's see the result. So unfortunately, that was not true. Let's check the A. If the A, let's see where is the correct answer. Click A, Mohab. كليك بي. خلينا نكليك عشان نشوف الإجابة الصح إيه. B. Okay, next question. The lazy eye hitters.
Yeah.
Are you ready?
Yes, we are.
Yeah.
I have a little bit confusion. They asked for Joker. Why we didn't see the results for the Joker? I mean, where was the help?
Where was what? You choose the Joker for one question of 5.
The results. Only to duplicate the results.
But if they got the correct answer, you'll get 2 instead of 1.
Okay, so it's not kind of help. It's just duplication of the. Okay.
Yes. Giving you an extra mark if you corrected answer. If you had the correct answer, give you an extra mark.
Okay,
Okay, I'm reminding you that you still have another help, the audience vote. So if you are not sure with your answer, at the end of the 40 seconds, you can ask for the help of the audience. And please, I'm asking the audience to keep ready with us for this option. You still have it. Okay, so remember that the choose for Joker should be before choosing the question. Okay, you have it. So the team lazy eye didn't use the Joker yet also. Okay, so the question about advanced strabismus. Choose which number from those
okay,
except 2 and 4.
I'll go for question 3. 3.
Okay, let's see question number 3. Ready?
Yeah.
Which of the following statements is false? Again, we're asking about the false regarding optokinetic nystagmus. Okay, concentrate. The first option is which is false regarding optokinetic nystagmus. The first one is the slow phase occurs in the same direction as that in which the repetitive visual stimulus is moved. Number 2, the frontal lobes control the slow pursuit movements. Number 3, in the patient with congenital motor nystagmus, a reversal of optokinetic nystagmus response can occur. Number 4, an optokinetic nystagmus response elicited in an infant indicates that some visual input is present. You have 40 seconds from now. Discuss with each other.
I would go for B, Joyce, Dua, and Asma. So B is my, it's the false because I guess the parietal lobes are controlling the pursuit movements. What do you guess? Dua, Joyce, Asma.
Yeah. Is that B?
Joyce?
Yeah, B.
B, okay. Dua, are you sure from A? Would you like to ask for audience help or?
No.
Okay, so I would choose the answer B for our final.
جواب نهائي.
إن شاء الله.
طيب اوكي B. They choose B. خلينا ندوس على B. They choose B. اللي هي تاني واحدة. طيب انتوا قلتوا B اللي هي الفرونتال لوب كنترول ذا سلو pursuit movement. انت كنت مترددة هي frontal lobe ولا parietal lobe. You were confused about this.
No, I said that the parietal lobe is controlling the slow pursuit movement.
طب يعني what about A?
So this one is false.
I think.
Do you think about A that the slow phase occurs? It's saying that it's the same direction with the repetitive stimuli.
Okay, what do you think of? Well, should we ask for audience help?
لا خلاص انتوا اخترتوا.
I think we have to stick with B.
بقطمكم بس يعني.
أنا بقطمكم بس.
Okay, it's all right. Let's see.
Best, I am playing with the nerves. Playing with your nerves. That's what I.
Okay, and you have done that already.
Okay. Okay. Let's see if it is correct or not. Let's see the answer.
Yay.
Wow. Correct. Definitely, you're right. The frontal lobe actually is the first for the.
Yeah, the frontal lobe for the saccades.
Yeah, that's
The
right.
fast.
Yeah.
Thank you.
Yeah.
So we have 2-0. So we have 2 and 0. The score till now is 2-0. Brown, you should do the maximum that you can in the coming 3 questions. Please concentrate as much as you can. The Brown team, let me double check if you are ready. Are you all ready?
Yes.
Muhammad,
Yes.
Riham.
Yes.
Yes, I'm ready. Yes.
We have the 2 Rihams with us, or still we have 1 Riham?
Both of them are there.
Yes, I'm back. I'm here, Dr. Ayman.
Yeah, welcome. Okay.
Okay.
طيب جاهزين؟
Yes.
Yes.
يعني تحبوا تشربوا ليمون او حاجه تهدوا اعصابكم؟ Drink something.
Go ahead.
طيب
No
okay.
problem.
Okay, now the third question about pediatric anterior strabismus. Sorry, predatory anterior segment, which include cornea, lens, and glaucoma. Choose one.
Question 1.
افتكروا, you still have رأي جمهور. You still have audience vote. Then as an option if you fail. Okay, anterior segment.
Question 1.
1. Okay, question 1. The question is, the following features can be associated with axon field radial anomaly except limbal stem cell deficiency, posterior embedded toxin, glaucoma, pseudopolyuria. You have 40 seconds from now.
Number A.
That's right. I'm going with A too. A will be will be with inoredia. Anyway, axon field has posterior embedded toxin, glaucoma, and pseudo polyuria. Okay, yeah. So we will take number A.
جواب نهائي.
جواب نهائي.
Final answer.
Final
A.
answer.
So اختاروا A. Let's choose A. Please مهم. Click on A. Okay, دلوقتي معانا number A ومنتهى الثقة. بس يعني I would like to mention to you that if you lost this question, you will be
out.
and you have 2 only, and they have 2. And you didn't ask for audience vote. You had this opportunity to have the audience vote. You had this opportunity.
But this time,
and
we are
Riham,
concentrated.
yes, and I think Riham asked you about this. I'm sorry for this. Let's see the answer. Yes. So we are still in. The Brown team is still in. The Brown team is still in with us. Still have the it's 2-1. We still have opportunity. Okay, lazy eye hitter. Are you ready?
What do you use? The Joker Dua now? Or
yeah, I think we might use the Joker. What do you think, Joyce and Asma?
Okay.
Okay, Dr. Ayman, we would like to use the Joker.
Okay, that's great.
Okay, I would go for question number 5. I would go for question number 5.
Question 5. Okay, yes. Okay. The question is, which of the following is a diagnostic feature of primary congenital glaucoma? Bilateral optic disc cupping by more than 0.6, asymmetric size of the globe, cornea diameter more than 14, Hab stria. You have 40 seconds from now to think.
I think C. What do you think, Joyce and Asma?
But they all could be features of glaucoma.
Yeah, but so one time I heard someone calling that corneal diameter more than 13 would be diagnostic because Hab stria can be present in normal kids.
What about megalocornea?
No. Hab stria cannot be present in normal. Really? Yeah, corneal diameter could be enlarged in megalocornea, asymmetrical size of the globe, maybe in high myopia case.
We're running. So, okay, D. What do you think, Joyce? D?
D, yeah.
Okay, so we would go for D.
So last answer is
D.
D. D.
Okay.
D. Okay. D. Which of the following is a diagnostic feature for primary congenital glaucoma?
I'm not convinced, but yeah, I will go with the.
Why did you his vote? You still have Woodin's vote. You still had it, but you lost it now.
Oh yeah, okay, that's fine.
The corneal diameter is it a must to be above 14?
It's
No,
we still can have.
No, not above 14. It's not above number 14. There is no any infant above 12 millimeter cornea will become high corneal diameter. It's not a significant or not diagnostic tool for congenital glaucoma.
And the asymmetric size of the globe?
No, asymmetric size definitely wrong.
Yeah.
Okay, let's see.
Okay.
Let's see the
Good job.
Oh, there is a hitter at 3.
No, we don't have 3. We have 4. We chose the joker.
Oh, joker. I'm sorry. I'm sorry. I'm 4. I'm very sorry. That's
You're cheating.
I'm sorry. Joker. We have 4. And the brown has
Only
1.
one.
And they have 2 questions without joker.
So
I
we are
don't think
now
you
out.
get it, but I think you have the right to have 1 more question. Okay?
Is it all right? Okay. Okay.
يعني نديك فرصه كده بس ايه يعني جول الشرف زي ما بيقولوا كده يعني you have opportunity to have one more question.
Okay, when we have the chance, okay.
Okay, let's have one question for Brown. Because we have to continue. Yes, that's important. We have to continue the match because at the end, the total score, because the lazy eye hitter team you have to know what the score they have to compare it with the other teams when they play. Okay, so let's go for the question: pediatric posterior segment.
We will choose number 1.
1. Okay, 1. The question is, the most probable diagnosis for these 2 pictures is toxocara, PHPV, Coates, medulloblastoma, medulloepithelioma.
I think it will be. What do you think?
Yes, it's P.
Because there's a connection between the optic nerve to the lens, and you see the leukocoria.
Yes, I can see the PHBV.
Okay.
Connecting the optic nerve with lens. Okay.
Okay, so all of you? Okay, so we will take B. PHBV.
You have the last answer.
PHBV. P.
B. So please choose B. You're confident you choose PHPV. Why didn't you choose Coates?
Because there's no
Coates cause the oxidative retinal attachment.
Yes, and what do you see in the imaging? I thought you would have PHPV.
Connecting stalk between the optic nerve and the lens.
Okay, let's see the results. Wow. Good that you have been asked. Okay, so for lazy eye team,
I would go for question 4.
okay, good. Concentrate. You are not competing only with Brown. Remember, you are compete with the other teams. You still have 6 teams, 2 teams tonight, and 4 teams in the next time. So remember, you should still fight for every point. Okay. The question is, this picture is a picture of active retinoblastoma, Coates, fish flash response to chemotherapy, toxocara. You have 40 seconds.
To be honest, I have no idea. Dua, Joyce, and Asma, and I would like to ask for audience help if one of you is not sure. Are you
yeah,
sure?
sure. Well, I think it looks like retinoblastoma. It could be.
Yeah.
Because
I'm seeing an exudate around it.
Okay, yeah, and this can be coats. So what?
No. It's not an exudative. It is
Yeah, it's more like a mass rather than exudative RD. And Toxocara, I presume, is usually more peripheral. I don't know.
Yeah.
I'm not sure what fish flesh response is.
Can we ask for audience help? I would like to ask for audience help. What do you think? Okay. I would choose audience help if that's possible. Dr. Ayman?
Okay, you have the right for this. Okay, for now, for our audiences, please prepare. You have 10 seconds to answer and help Lazy Eye team. Let's see the results. 67% used the first option, active retinoblastoma. 22% used fish flesh response to chemotherapy. So you have the right to choose this one or to change it, but you have only 5 seconds.
Okay. Okay, let's go for A. We're
Okay,
already
you trust our audience?
Yes, definitely, yeah.
Okay, so it's A.
Okay, yeah, A.
Okay, so let's see if it's correct or not. Thanks to our audience. You have to thank all the audience.
For
one
nothing,
by one.
Thank you, everybody.
Thank
you.
Okay, now we have good news for the brown team. I have good news for you. There was one question. There was a mistake in its answer.
Fine.
Typing
Fine. That's fine.
Yes, I
So,
felt
but-
this. That's why I double checked with the professor who put the question. During this time, I was communicating with him about this, and I got the right answer for it, which is I believe in it, and I believe it was right. It's the question with emmetropization. Okay, and he confirmed with me that the answer that has been put was not right. Okay. So let's get back to this question. I'm asking Muhab, can we get back to this question just to make sure the number? It was, which of the following is not true regarding the trend towards emmetropia in the pediatric population? Yes, you choose, I think, what did you choose?
P. We have choose P.
Okay. Well, and it was, okay, yes. I think, yes, I think this question was at the service. So I repeat the question for you. You will choose another question from this category.
Okay, and we have
of course, we're not repeat the
joker.
answer to this. You have to show the answer.
Okay.
So, but to repeat the question. So you are going to choose another question in the category. I think it was an advanced strabismus. Am I right? That reminds me.
That's right. That's right. And we have a joker in this question. So
the joker in this. Oh wow! The match my reverse. Wow.
Okay.
The match my reverse. Okay. So I think the lazy eye hitter, they can understand this, and they can. I think they agree with this. That's to be the first thing. Okay. So we will repeat the question of the advanced strabismus. You would choose another question. That's why we have spare questions, as you can see.
Okay. So which question will we choose now?
What about number 6?
Okay, so
we'll choose number 6.
Brown team, question number 6, and it's Joker. Let's see, well, they're very exciting. Okay, which of the following cases is at highest risk of amblyopia? Which of the following cases is at highest risk of amblyopia? Congenital esotropia, 40 prism diopters at 8 months of age with bilateral +3 refractive error, not wearing glasses. Intermittent exotropia at 40 years of age with right eye -2 and left eye -3, not wearing glasses. Anisometropia with the right eye -10 and the left eye plano, compliant on glasses. 3 years old with high AC ratio with 40 prism diopter esotropia for near and on distance with the distance deviation, and not improving with bifocal.
I suspect number A. Number A.
رأيكم كده برضو؟
Which of the you have 40 seconds?
Okay.
I'm confusing with number D.
Number D. Me too. So we will take the audience point of view.
Okay. Yes, good idea. Audience, please, you can help the brown team to get back from 1 point to 3 points. Please, the audience, I'm asking the audience to start voting. Which of the 4 to choose? You have 10 seconds. Which of the following cases has the highest risk of amblyopia? Congenital esotropia, 40 prism diopter, 8 months with bilateral +3. Intermittent XT, 40 years of age, -2 and -3, not wearing glasses. Anisometropia, -10 and plano, compliant on glasses. 3 years old with high AC ratio, 40 prism diopter near. Let's see. We have 39% choose A.
I selected this from the start.
Okay, so no problem. So we will take number A.
39%.
Okay.
It's only 39. It means that not the. I mean, it's the highest number.
Yes.
Less than half, a third of the audience believe in this.
Inshallah.
Okay, so we will take A.
Go for A. Okay.
Okay, so we will take A.
A. You have only 39%. You had only 39%, which means you had 61% of the audience not agreeing about A, and you got this opportunity. That was the last chance for you.
Yes.
To get back in the match.
Okay, I know. I'm with the democracy, so it's okay.
Let's see. What's
fine.
Perfect. That was a good choice. Thank the audience. We have to, again, both teams should thank the audience one by one.
So
okay,
we take 2
now,
points or what?
You have 2 points. So the second question is 2.
Okay.
So now the score for the brown team is مين بيتابع السكور؟ احنا 3 كده؟
Yes.
3.
We have 4 points, and Brown and the other team has 5 points.
5 points. Lazy, yes.
Sorry, Brown has 4.
4.
Yes.
Lazy, I 5.
Yes. Okay. Okay. Yes, that's right. And the Brown has been asked about the retina question, right?
We have already answered the retina question, and
yes,
it was
okay,
right.
yes. Okay, so now they are the final question. So now both teams has been asked 4 questions. Okay, correct me if I'm wrong.
Yes,
the lazy hitter has 5, including the joker, and the brown has 4, including the joker.
Yes.
Correct me if I'm wrong.
Yes, Dr. Ryan.
Yeah. Okay.
That final 5th question is final. I'm happy the brown had came back. So if the brown had a correct answer this time and the lazy eye hitter wrong answer, they will be equal and we will go for the penalties. Okay, brown team.
It's really exciting.
Get ready for the 5th. I'm excited. It's really excited. The 5th, and I can stay with you 2 hours in this. I'm enjoying this. The 5th question. The 5th category, neuro-ophthalmology and occuloplasty. Actually, this was supposed to be one of the toughest questions. Which one? Choose the number.
So what will we take? Number 1, 2, or?
عايز مساعدة.
One, okay. We will take number 1.
Okay, number 1, the first question. 5. Wow. Okay. Look at the pictures and name this syndrome. Is it 1.5 syndrome, 8.5 syndrome, 13.5 syndrome, 16 syndrome? You have 40 seconds.
Okay. So I think it's 1.5 syndrome. What do you think?
I don't know any B or C or D. It's 1.5 syndrome.
No, it's it's maybe the patient has a facial palsy, and
Yes, and some blepharospasm.
no, I don't know. I would take number A.
Okay, go for
Go for what? A. Okay,
I don't know
number
any
A.
of the
Number A.
others, yes.
So
Number A.
the final answer, think about it. Look at the 3 pictures and tell us what's your final answer.
Number A.
Okay. جواب نهائي.
Yes.
Okay.
You are confident with this?
I hope so.
Yes, number A. Inshallah.
Okay, you choose A. يعني have you looked on the picture with the facial palsy?
Yes,
I agree with you that the pictures with the motility goes with 1.5 syndrome, but it's not only that picture.
That's right.
I really wish that you can continue. You could continue. I really wish for this. Okay, let's see the answer. Unfortunately, that's not
okay.
The correct is, as Dua said, it's B. Let's see the B. This is right. We have facial palsy plus the 1.5, 7 nerve palsy plus the 1.5.
Yes.
Okay, so the lazy eye hitters, the last question, actually, they won the game. Congratulations.
Thank you.
This match. Congratulations for the lazy eye hitter. But still, you have to you still have one question. If you got it right, you will get the full mark. Wow, you will get things very hard for the next 2 teams. I really wish you got it wrong. I really wish. Because the next match, if anyone knows the question is out.
Yeah, with full respect to the non-Arabic speakers, صلي على النبي دكتور أيمن.
طيب. يلا اوكي.
I would go for question number 7.
7 حاسس انها سهله 7 دي.
ربنا يستر.
كويس انك اخترتي 7 بقى. لا كويس كده. كويس يلا question number 7. يلا بالشفا بقى. This is a premature closure of frontal suture, frontal lambdoid suture, sagittal suture.
Okay.
You have 40 seconds.
Okay.
Is that the sagittal suture? Because the head is like long.
Yeah, it
like
is
this.
elongated in fronto-posterior direction. So
I think it's D then.
So the sagittal suture, yeah, is the one which is prematurely closed because, yeah.
No.
Yeah.
Look for his forehead. His forehead is normal. The lambdoid suture.
10 seconds.
It is elongated. It is elongated in an anteroposterior direction. So the midline suture all through.
Go for C. Go for C. Go for C.
I would choose D. I'm sorry, Dua. I would choose D.
I am a best pediatrician.
Wait, the team leader is Dr.
I have
Gamal.
I know, Dua, with the full respect, I would give you money for compensation if we lost.
What?
But I would go for D.
The team leader, what's the answer? Dr.
D.
Gamal. D.
I'm so sorry, Dua. I'm so sorry. I would give you money for compensation if we lost.
دعاء أصلا ماشي كويس من الأول.
والله, I still would go for D because it's an anteroposterior elongation. So the primary suture, which is prematurely closed.
It's up to you. If you're gonna lose this mark.
Okay, let me just a second.
You will lose the opportunity of.
Oh, are you sure, Dua? Are you sure, Dua?
Okay, so that's time. You have to give us an answer.
Okay. So, are you sure, Dua? Okay, are you sure? Are you sure?
Not sure, of course. If I was sure, I was insisting in this
okay.
answer.
Answer is we're gonna lose. Answer is Dua Gamal.
D. Okay, D.
D. Okay, choose D. سارة. وسارة فعلا.
والله.
خساره كان نفسي تخسروا
What
في
is it?
السؤال ده. Show us the correct answer. Show us the كان نفسي تسيبوا فرصه للي بعديكوا. You got the full mark. 6 out of 5 questions. Wow.
Thank you.
Perfect.
I'm so sorry, Dua. You owe me money. You owe me money.
No,
Thank you very
I
much.
will not.
Thank you. Thank you. I would like to
Thank
thank,
you.
first of all, I would like to thank the Brown team. The Brown team, final score is 4. The lazy hitter, the final score is 6. So I would like first to thank the Brown team. You did a very good job. I'm sorry, I will start with you. You did a very good job. Thank you very much. Thank you for the Brown team. Dr. Muhammad, Dr. Riham Fawzi, Dr. Riham Samir, Dr. Isra, thank you. Thank you very much. And for the second team, Lazy Eye Hitter, I would like to congratulate them. You did a very good job. You did an amazing job. You got a full mark with the joker, everything. Dr. Dua Gamal, Dr. Joyce, Dr. Dua Ashraf, Dr. Asma Fouad, and the most important, I would like to thank the audience who held the 2 teams in 2 questions. Perfect. Thank you. And let's go for the next competition. And for the audience, don't leave us. We will need you in the next team, in the next bench. Dr. Sameh, I want you to take over.
Hello, Dr. Ayman. Thank you for
It was very interesting. Very, very interesting match.
Yes, I really enjoyed, and I think it's more exciting now to go for the second part of the competition. So let me welcome the coming 2 teams, RBC Warrior team, Specialized Center of Strabismus from Syria with Dr. Wael Hamouda, Dr. Wala Saqa, Dr. Nawar Shuhada, Dr. Alaa Al-Awadi, and RBC Warriors, Dr. Jonjan Longo, Dr. Aisha Samabni, Dr. Turab Vermi, and Dr. Kartika. I'm sorry for pronouncing any name in the wrong way. How do you feel before we start? You feel well?
All good.
Yes.
Yes. So I'm just trying for a couple of weeks to be scary, but I don't know I will succeed or not. So now you all know the rules of our competition. So we'll start with the Specialized Center of Strabismus. Dr. Wael Hamouda, are you ready?
Yes, I am ready.
Dr. Nawar Shuhada and Dr. Al-Awadi will start with the Specialized Center of Strabismus. And
excuse me.
Yes?
I have one doubt. What was the score of the specialized strabismus team for choosing them first? Like we had more scores than them, I guess.
Again, please.
For the audience poll. For the audience poll, RCC Warriors had a higher score, I guess, for the first teams which were selected.
I think let's go back for
Please
the
check once.
the results of the
As
vote.
far as I remember.
Okay, let me check again, please.
Yep, sure.
What about the results of voting?
Okay.
Can you please tell us the voting? Okay, so
RBC.
should start. I'm sorry.
RCC Warriors can go first. Yep.
Sorry?
Fine.
Okay.
Fine. So RTC Warriors have.
I'm sorry for that mistake. So let's start with RBC Warrior team. Dr. Georgian Sluja.
Gunjan, yeah.
Okay,
It's
let's
Gunjan.
start with our sorry, didn't you name?
Gunjan, G. It's Gunja.
Okay, Gunjan. Okay, Dr. Gunjan, let's check which question you want to choose from first category of questions, basic strabismus.
Question number 3.
Okay.
Question number 3.
Start with Joker. You have 2 helping methods, Joker and audience vote.
So for now, just a normal question. No Joker.
Okay.
Question number 3.
3.
Yeah.
Okay. Let's go for basic strabismus. According to Pediatric Eye Disease Investigation Group studies, which of the following factors would cause a significant decrease in amblyopia recurrence after stopping patching? A. Final visual acuity of 6/6 in both eyes, good alignment with no strabismus, high-grade stereo acuity, tapering, patching from 6 hours per day to 2 hours per day before stopping. You have 40 seconds from now to decide which answer you would like to choose.
Okay. Kartika, I cannot see my other team members.
High grade vision.
Yeah, we can hear you, Gunjan.
Yeah.
I think
D. I'm choosing D. D. Kartika, where's Kartika?
B.
Where's Kartika? D.
D.
Yeah, my answer is D. D. Our answer is D.
So, Dr. Jordan, your final answer?
D. Option D. D option.
Fourth answer.
D.
Yes.
Okay, tapering batching 6 hours per day to 2 hours per day before stopping. Okay? This is your choice?
Yes.
Yeah, D.
Okay.
D is the final choice.
Okay, so RBC Warriors choose number D. Do you know the study? Basic study?
Yes. The
So
80 is grown, so it's D because that is what we are practicing here also. We taper it to minimize the recurrence.
Okay, so you are sure?
Yes, we are
If
sure.
not,
I
who
think
will take the bench?
most probably it's D.
Okay, let's go for
Let's see. Hopefully it's D.
the correct answer. Oh, this is the first mark in our competition. Thank you, Dr. Gunjan. So going for the same category of basic strabismus for specialized center of strabismus. Dr. Wael, which question you want to take? You have one of three choices, 4, 6, and 7. 4. So let's go for question number 4 in basic strabismus. Type 1, congenital fibrosis of extraocular muscles, is the most common type of congenital fibrosis of extraocular muscles. Which of the following is not a feature of this type? A, horizontal motility is usually normal. B, it is autosomal dominant with full penetrance. C, superior rectus is atrophic. And option D is usually associated with bilateral ptosis. You have 40 seconds from now.
The most common is not feature.
B.
I think it's A.
Yes. Okay. A.
Final decision?
Isn't a feature of this type, Dr. Wala? Wrong. Horizontal motility.
Dr. Wael, your final decision?
Wrong. A.
Okay, so our time is out. What's your final answer?
A. Horizontal motility is usually normal.
Okay. So, specialized eye center of strabismus have number A choice.
Okay.
Are you sure of this answer?
Yes.
Yes.
Okay. I hope it will. So let's go for the correct answer. Wow.
Yes.
Third center of strabismus answer. And back to the Warriors. I think you will have the choice with Warrior Spirit. So, second question will be for advanced strabismus. I'll always
Question number 1.
Sorry?
Question number 1 we would like to choose for.
Okay, let's go for question number 1. Do you like to take Joker?
No.
Okay. When is artificial divergent surgery is indicated for nystagmus? A, when Kestenbaum-Anderson procedure causes an overcorrection. B, when nystagmus type is fusion maldevelopment, manifest latent nystagmus. C, when the child has esotropia more than 30 associated with nystagmus, or when head posture improves by base out prisms.
Okay, I would like to discuss. Asha. Other team members, please. Dr. Kartika. I cannot see my other team members.
Use audience poll. Audience poll.
Audience poll.
Okay, so you want to go for audience vote?
Yes.
Can you please prepare the audience vote? So we have 10 seconds for audience to vote for A, B, C, and D. Oh, now we have 41% voted for number D, 31% for number C, 15% for number A, and 13% for B.
Go with the audience poll.
So audience will go with audience.
Yes.
Option D.
You'll go with audience.
Option D.
Option D. Okay, let's fix option D. Final answer.
Okay.
Do you trust your audience?
Yeah.
They know you are warriors, so they are scared.
You can say.
Okay, I hope audience will be rescued by your answer.
Yeah, we'll stick D option. Okay.
Okay, let's check for number of the correct answer. Oh. Okay. Thanks to you.
Thank you, audience.
Thank you.
So next question for specialized center of strabismus from the second category of advanced strabismus. You have one of two choices. Question number 2 or number 7.
2.
Sorry?
2.
2. So let's check question number 2. Which of the following is the highest risk factor for Holden-2 syndrome, PITS, during muscle surgery? A, old age. B, Duane syndrome. C, working on the lateral rectus in cases of exotropia. Or D, previous Hatem procedure.
So put it in 2 syndrome. I don't know. Duane syndrome?
B.
B. Duane syndrome.
B.
From
نهائي.
the audience.
Hola.
Yes.
Duane.
Audience.
Audience?
Yes.
Okay. Let's check the audience. Audience voting for the answer. A, B, C.
Already. ما طلع في هذا.
انه بتقلب من تايب لتايب.
Okay, then.
Voted for number B.
Yes.
Yes, B.
And sorry, your final answer?
B. Duane syndrome.
B. Okay. We'll fix it?
Yes.
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 Okay. What did you think about previous Hatem procedure?
I don't have any idea.
You think it's at a higher risk or a lower risk?
Dr.
Okay. So you trusted your audience?
Yes.
Yes.
Can you tell me if it's wrong? I'm sorry, it's a wrong answer. So let's go for the correct answer. You just betrayed me. Okay.
Sure. Old age.
Back
Old
to
age.
RBC Warrior team. Category number 3.
So I'm going with the question number 3. I'm going with question number 3. Okay, question 3. I think other two.
Question number 3.
Use kare.
3
Yes. 3, okay. Yep. Fine.
The following is true about anterior lenticonus. A. Most unilateral cases are associated with Alport syndrome. B. It's caused by mutation in BAX6 gene. C. The X-linked type is often associated with dot and flick retinopathy. D. It's never associated with posterior lenticonus.
Dr. Saurabh?
I think that's B होना चाहिए.
B or A, Alport's anterior lenticonus unilateral, but it's bilateral. I know.
The anterior lenticonus
is associated with
Alport में होगा ना, लेकिन वो
Alports.
bilateral होगा कि
bilateral
unilateral
होगा. Bilateral, I guess.
ट्रू लेना है ना. अच्छा टाइप 4 कोलेजन के साथ कॉल 4A से होता है Alports तो.
Okay, so I'm going with A or C.
A. Final answer.
A.
Oh, wait a minute. A.
A.
Okay, A.
Okay.
Yeah.
Your final answer is A.
A.
So you think anterior lenticonus is mostly unilateral?
यार नहीं पता यार.
And unilateral
Never, लेकिन ऐसा लिखा थोड़ी है कहीं पे कि.
I think the X-linked is associated.
Is it written somewhere कि it won't be associated with posterior?
Usually the C होता है. Then stick. Now we are selected.
Let's
C, I guess.
Correct answer?
Okay. Yeah.
I'm sorry, it's the wrong one.
Yes.
What's the
It's C.
one?
I guess it might be C then. C, yes. I guess.
So if you think after end of competition, please send us videos. Let's go for the fourth category of questions. Sorry, second question for specialized eye sensor in anterior segment category. Dr. Wael?
We can use
Joker.
Joker.
Yes, sir.
Okay.
7.
Number 7.
Number 7.
Okay, let's go for
7.
The infant attention frequency study was designed to compare the results of A. Primary intraocular lens implantation versus contact lens in infants with unilateral cataracts in the first year of life. B. Primary IOL implantation versus contact lens in infants with bilateral cataracts in the first year of life. C. Primary IOL implantation versus contact lens in infants with unilateral cataract in the first 6 months of life. And D. Primary IOL implantation versus contact lens in infants with bilateral cataract in the first 6 months of life.
A or C?
C.
C. A. C, I think. Dr. Ala.
C.
C. Why? Ala.
Dr. Wael, your final answer?
C.
C.
C. C.
B or C؟
خيار الثالث.
ثالث.
خيار الثالث.
نيم؟
Number 3.
3. Okay. Primary IOL implantation versus contact lens in infants with unilateral cataract in the first 6 months of life. This is your choice?
Yes.
Let's fix answer number C.
Bismillah ya Rab.
The result of infant efficacy study. Okay. Let's go for the correct answer. Correct? We realize. Okay, let's go for RBC warriors and category number 4, pediatric retina and oncology.
Okay, so we would like to use Joker in this.
Joker, okay.
Joker, we would like to use Joker.
Okay.
And I'll consult my other team members also. Which question should I choose? 5. Okay, I choose question number 5.
5.
Question number 5.
I hope you are not like the other team in your Joker. So investigations need to diagnose the disease. In this picture, ultrasonography, B, MRI, C, fluorescein angiography, and D, torch.
Fluorescein angiography. C.
Fluorescent, it's toxocara, I guess.
या टॉर्च करें क्या मतलब जैसे
Diagnose.
See, ultrasound will not help.
ultrasound
MRI is not a. MRI
MRI
can help to differentiate it from retinoblastoma. Torch profile for the
टॉर्च
definite
प्रोफाइल टॉक्सोकारा के लिए हो जाएगा
toxoplasma.
I think it should be
torch. Torch.
Diagnose पूछ रहा है ना?
हाँ टॉर्च D.
Torch should be torch.
D.
Okay, D. So our option D. I'm going with D. Torch.
Me please. Torch. Okay. D.
Torch.
Okay. You said ultrasound will not help.
Am I right?
What about fluorescein angiography? Would it help?
Fibrosis, I think it will help. There's a macular drag along with scarring, most likely.
Don't you think about MRI?
MRI can differentiate.
How can MRI differentiate?
MRI won't. Actually, CT will help to differentiate it from retinoblastoma. Differential ke liye, for leukopenia.
No, but different.
This is a question. So let's go for the correct answer. So in both teams, you have 2 marks in each question with Joker. So you are both lucky. So our last question, our fourth question for team Specialized Center of Strabismus in pediatric retina and oncology. Which question you'd like to take?
Two.
Okay, let's check for question number 2. This retinal lesion is retinoblastoma stage A, B, retinitis, C, astrocytoma, D,
Astrocytoma. في التصلب الحلبي. astrocytoma. C.
اوكي هذا تصلب حديد.
الخيار الثالث.
سي.
astrocytoma.
سي.
Final answer?
Final answer.
Okay. You are all convinced? All the team?
Yes.
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 Okay. So no one to punish if it's wrong.
No.
I don't think so.
So let's go for the correct answer.
Yes.
See, now asked 4 questions. And you have the both marks of Joker question. So now 4 versus 4. Let's go for the last question. And
देखा जाएगा जो होगा.
RBC Warrior. Which question you'd like
Which
to
question should I choose? Yeah,
Yes.
that's what I'm asking my other teammates.
Which question will
No,
you
we have
choose?
used
Joker ले लो.
question number. No, we have used it in the last question.
हो गया था.
We have used it in the last.
हाँ.
वो torch वाली.
कोई भी ले लो यार.
5 या 6 ले सकते हैं.
6. Okay, I'm taking 6 then. Okay. Question number 6.
Question number 6. Okay.
Yeah, 6.
Let's go for question number 6.
हेल्प करना होगा.
The most common type of epicanthus seen in Asians. You are lucky because you're Asians. A. Epicanthus inversus. B. Epicanthus palpebralis. C. Epicanthus supraciliaris. D. Epicanthus dorsalis.
शायद टार्सालिस है. या बी होगा या डी होगा. या बी होगा या डी होगा. मोस्टली डी होगा.
Tarsalis.
मोस्टली डी होगा.
Okay. Okay, then I'm going for D only then.
हाँ कार्तिका डी होगा ना. देखते हैं डी.
D. Tarsalis. Okay. D. Option D. We would like to go for option D.
4. Okay.
Okay.
Okay. Epicanthus dorsalis.
Yep.
So your choice is Epicanthus dorsalis. All of you agree?
Yeah. D. Yep. We're choosing D.
Okay. So let's check the correct answer for equations.
जल्दी बताओ ना यार.
Oh.
Yeah. I have.
So good.
Still be
True is the
answered
issue.
one question.
हमारा टाई हो गया क्या?
And now we have 5 marks for team RBC Warriors and 4 marks for stress center of stimulus before the last question. So you have the chance to go for a penalty if you answer.
What is the question? Which is the question?
Which one you like to choose of these questions?
4.
4. 4.
4. Okay. Question number 4. Congenital epilepsy might be associated with weakness of which one of the following muscles? Inferior oblique, B. Inferior rectus, C. Superior oblique, D. Superior rectus.
هاي بالجلد. B. Inferior rectus.
Inferior rectus, number B.
Yes.
Are you sure? Final answer?
Final.
Fine.
Not a 0.
What do you think, Dr. Wael?
I don't have idea.
You are going for the penalty question or you will withdraw? What's your expectations?
I don't know.
You don't know. So you are not sure. Anyway, it's a very nice game because you are going like step by step. So let's check for the correct answer of congenital epilepsy. sorry for you.
I think it's oh.
You think it's what?
Wrong.
Okay, it's so let's check for the correct answer now. So now we have 5 marks for Team RBC Warrior team and 4 for Sterile Center of Strabismus. So the winning team for this match is RBC Warrior team. Congratulations and good luck, Sterile Center of Strabismus. Thank you very much.
Thank you. Thank you.
Thank you.
I enjoyed this competition very much, and my comment by the end of this competition, actually, the level of all young ophthalmologists is exceeding what the young ophthalmologists level. Like all are doing like an expert level. So my real congratulations to all your participations. Back to you, Dr. Ayman.
Yeah, that's very interesting. Very exciting, and we are now with the winner of the whole 4 team is the lazy eye hitter. Congratulations. The lazy eye hitters now are the winning team for tonight.
Thank you.
This is the winner team: Dr. Dua Gamal, Dr. Joyce Shan, Dr. Dua Ashraf, Dr. Asma Fouad. But yet, this hadn't been finished. This is not finished yet. We still have a second episode. We'll have another 4 teams playing. Lazy Eye, they got 6 out of 5. They got the full mark. So in the next episode, when we have the 4 teams playing, if one of these 4 teams got 6 marks, you will have penalties questions with them. So please, for this team member, be ready for the announcement of the second episode. And in the second episode, you will be invited to be in. Just in case one of the 4 got 6, you got penalties for them for the winner of the whole competition. Congratulations. I'm asking all the audience to congratulate them. That was perfect. So now the last thing to conclude. Now the scoring. The scoring for the talks in the first section. Dr. Heba were doing a very good job. She received the scoring from the judges. She wrote down the audience response. We added both and got a mark. And Dr. Heba will announce us for the 3 with high score. And okay, Dr. Heba, the mic is with you.
Okay, thanks, Dr. Ayman. But let me first congratulate the Lazy Eye Hitters team for to be the winner of this event. You really deserve it, and you're so lucky. All the 4 teams are so lucky. You skipped my penalties question. I was voting for you all here with penalties question. Congratulations, and let me now tell you the highest 3 scores of the free talks session. The highest 3rd score is Dr. Isra Muhammad Abdelmenaim from the Research Institute for Ophthalmic Research. Congratulations, Dr. Isra.
Congratulations.
Congratulations. And so the next 2 highest talks are for Dr. I want to tell you that the highest 2 scores will be available for the next event, because we will have at the end of the 2 events 2 prizes for the highest 2 scores, and so the highest 2 scores of the free talk session are very important and are very having a very high opportunity to win the prizes. And now I will tell you the second highest score. Let me drink some water first.
What about your first Oscar, Dr.
It's my opportunity long ago. So the second highest score is Dr. Nuran from Qasr Al Aini Hospital. Congratulations, Dr. Nuran. And the highest first score goes to Dr. Smita Kapoor from India. Congratulations, Dr. Smita. Actually, you have a very, very interesting
Are you still with us?
presentation. Thank you. Thank you. You are the first winner of the free talk session of today event only is Dr. Smita, the first winner, and the second winner is Dr. Nuran from Qasr Al Aini Hospital. I ask you both, Dr. Smita and Dr. Nuran, to be available with us for the next event because we have two prizes for the highest two scores and highest best talks. I congratulate all the also Dr. Isra for having a very high score for today free talk session, and I congratulate all other speakers because actually you have a very, very interesting talks, presentation skills, and very high level of this topics of the pediatric ophthalmology and strabismus. Thank you. Congratulations, Nuran, and congratulations, Dr. Smita. Dr. Smita is still available.
Thank you, Dr. Heba.
Congratulations, Isra. Congratulations. Dr. Smita still available?
No. Congratulations, Dr. Isra. First, she's had the third place. Dr. Nuran is still with us. Dr. Nuran.
Hi, Dr. Ayman. Thank you.
Dr. Nuran, welcome in second place, and you will be with us in the second episode. Congratulations, Nuran.
Thank you. Thank you.
And the winner, the highest score, is an amazing high score, Dr. Smita. Are you still with us?
No, Dr. Ayman. No.
Okay. So Dr. Smita will be with us in the second episode. Very nice. I enjoyed it. Thank you. Sorry we kept you for 3 hours. I'm sorry for this, but it was very amazing. I wish we had 3 more hours.
Actually, we had a lot of fun and a lot of knowledge. Right?
Dr. Smita went out, so her prize should go for the moderators.
Okay, thank you very much. Thank you. I would like to thank my team. I will thank Dr. Sameh, Dr. Heba. You did an amazing job. I cannot imagine how the organization of such thing was really difficult. I would like to thank them. I would like to thank RM and Novartis for sponsoring this episode. This event. I would like to thank RM. They did an amazing job. I'd like to thank Mr. Chadi, Mr. Mohab, Lena, who else? All the team. I would like to thank all the team of RM. You did a very, very, very good job. You are professional. You're perfect. Thank you very much. And see you in the second episode. Looking forward for this.
Thank you, Dr. Ayman.
RM team, you can now go to sleep. You are awake for 3 days now.
You're welcome.
Yes.
Bye-bye.
Bye.
See you next event. We will announce for it on our web page. Bye-bye.